nurses and paramedics. You know that there are three important characters that one should have to become a doctor or a nurse or a paramedic. He should be intelligent, he should be skillful, and he should be compassionate. When we went to the market in search of the candidates, we got very intelligent, very skillful, but instead of compassionate doctors, we used to find commercial doctors. Every minute they were asking about how to make money, how can I get more money. Then this is where we struggled. Then Swami decided that we should have our own production center. Then the concept of medical college came. And we have started our own medical college here, where nursing, paramedics, and MBBS courses have started. Not only that, ours is the first medical college we started postgraduate course, DNB courses also. We have second year DNB courses are going on now. So almost all the courses we are doing, almost all the main courses we have done. In post-graduation, general medicine, surgery, OBG, pediatrics, and anesthesia, and radiology. These are the courses we are running. And happy to tell you that this year we are going to start CTVS post-graduation also. This is what we are doing. Most important about medical education is we are giving the medical education, nursing education, and paramedical education absolutely free. For them also, there is no fees, even for postgraduates. We are not charging. Only two conditions you have put. They have to be inside the hostel because they have to develop the culture of our institution. Second one is, soon after their graduation, they have to work, not serve, work for salary for same years of their study. For example, MBBS, 5 years they are studying, they have to work for 5 years. Meantime, if they get post-graduation, they can go post-graduation. If they get it in Mudenalli, they need not pay the fees. If they go outside, after the post-graduation, they have to come back and serve as that consultant. And if they get super specialty, they can go back once again. And after the completion of the super specialty, they have to come back and work as that super specialist. And according to that, we are going to give the salary. This is how we are doing. It's a unique nature. I want you to, after the completion of this course, I request you all to visit our hospital as well as our ashram, go through the campus, convey the message, good message of this institution to everyone. I know that this is the 10th year of our SCORE program, and I have taken a leaf out of that. I want to introduce these type of courses to other postgraduate courses also, so that everyone will be utilized. The toughest job for a postgraduate student is an examination. It has to be, and he has to come out colorfully out from examination. I wish you all be serious. Take every point what your seniors have come from all the way from outside and they are teaching you. I am 100% sure that all of you will utilize that their advices and take a note of it. And I wish you all good luck. Thank you very much.
Thank you, sir. We are glad to have you here, sir. So now we move on to the first session of clinical case presentation. In this round, there will be 3 presenters for a case, and one will present the case history and examination. Other candidate will discuss about investigation, and the third candidate will discuss surgical aspects. So questions will be directed to all of them. Questions not answered by them will be directed to the audience. And first bell will ring at 30 minutes. discussion and history and examination should get over within 30 minutes, and then we'll move further to investigation and surgical aspect. So total duration for the first case, we have allotted a bit more. It's around 1.5 hours. Because this is cyanotic case, I want it to be, we have to complete the surgical aspect also. So we have given a more weightage to this. We have given 1.5 hours.
Score.
So I call upon Dr. Pratik, Dr. Abhishek, and Dr. Prajita from Jayadeva Institute of Higher Medical Sciences. And examiner for this session are Dr. K.S. Iyer sir, Dr. Suresh Ji Rao, Dr. B.R. Jagannath sir, and Dr. P.S. Seetharama Bhat sir. Sir, kindly chair the session.
Thank you, sir. Thank you, sir. Yeah.
We have tried our best to arrange all the students not on the blind spot of the examiner. Otherwise, the students always sit on the blind spot of the examiner. So amongst you who are not MCH cardiac surgery students, you are okay. Not. What about those? Next four. You four ladies. What I mean, MCH, we don't try to catch me in words. This is not a court of law. You are cardiac surgery students. That's all I want to know. If I said MCH, I'm very sorry. So just want to identify. Okay? And we are going to give an official prize. I am going to give an official prize for a student who is actively participating. Usually the attitude is, tum aage badho, hum tumhare piche hai. So you bear the brunt and we will enjoy the fun. So either you have to pay entertainment tax or you have to face the brunt. Okay? Chalo.
Yeah. Dr. Iyer is there online and Dr. Suresh will be joining online. Yeah, online. Both are online. You have 2 mics with you. And the examiners can ask questions anytime.
I am sure we would have been happy if Dr. Raghupathi told that in this institute, MCH is also given free of cost, free without exam. But then you have to go through the ritual of examination. So this is mocking an examination. Okay. This is the rapid orientation course. So the thing will be something like what happens in the examination and what questions you can expect in the examination and what answer is expected out of you. Okay, right, start.
Just before that, if you have any questions to ask or if you have any comments to make, please do it in the microphone because it needs to be transmitted outside. And in the hall, we cannot pick up the things. Yashta.
Good morning, teachers. Good morning, colleagues. I am going to be presenting a case of cyanotic heart disease. He is Bipasa, 14-year-old male, presenting from Chhapra, Bihar. He had presented with complaints of cyanosis and easy fatigability for the past 12 years. At 2 years of age, he had noticed the mother...
The first question. This is the first question in your TOF patient. When you say cyanosis, what is cyanosis?
It is the bluish discoloration. The patient will be describing it as the bluish discoloration of the mucosal membrane and the fingertips. And it is seen when the deoxygen hemoglobin is more than 5 gram per deciliter.
You said patient will be saying.
Yes.
So patient says my lips are blue.
No, sir. Will be complaining of bluish discoloration of fingertips.
And patient will tell my absolute hemoglobin is more than 5 grams. Or you do an investigation
so we do
to find out an absolute So cyanosis is a clinical term or an investigative term?
So it is a clinical term.
That's all.
Yes. So
you repeat that answer again because this is the first question. You mug it up and vomit it out because the first answer itself is shaky, you get stuck in the cardiology, not in cardiac surgery. You get stuck in cardiology. So cyanosis is a fluid discoloration of skin and mucous membrane due to increased levels of unsaturated hemoglobin more than 5 grams per deciliter in the systemic arterial blood. This is the complete definition, and then you mug it up because this is going to be the first question. If the examiner thinks that you are well versed with that, the next question will be, what will be the saturation in a patient whose HB is 10 grams and he is cyanosed?
60s. It will be in 60s or 70s. If the HB is 10, so.
If the HB is 10, if the saturation is 60 grams, what will be the amount of deoxygenated blood in his body, in his arterial blood?
More than 1/3 of the total hemoglobin.
Okay. So
it will be unsaturated.
It will be how much?
It will be 36%.
It will be 3 grams.
Yes.
So will you detect a cyanosis?
Very my clinician can detect at 3 grams per deciliter.
So your 60% is wrong. So it has to be, the saturation has to be less than
5 grams.
50%. Then only your deoxygenated blood can be more than 5 grams. Okay. Go on.
At 2 years of age, the child had fever.
What is systemic desaturation? What is systemic desaturation? What is systemic desaturation? When you say saturation, at what time do you say it is?
Sir, 85%, sir.
The saturation less than 80% in the.
No. You all were in COVID. What was the first thing that you said? When do we say systemic desaturation? When is it overt cyanosis? When are you sending them to a COVID care center? At what saturation?
Just 90.
So that is systemic desaturation. When did you send them to the district COVID center?
90%.
No, 92. Why?
Why that 92%?
Sir, it's not related since it's a bell curve, sir. So that
Not a bell curve.
Okay.
Okay.
Now,
shape curve.
this cyanosis, you said from 2 years. What is its significance?
Sir, late presenting cyanosis, sir. Late presenting cyanosis. Delayed onset.
So at 2 years, are you happy, or when do usually these
Sir, around
cyanotic patients present?
anything after 6 months, generally, sir. So 6 months in 6 months to 3 years in cyanotic heart disease patients, sir, delayed cyanosis.
You have a child who is 12 years old.
Yes.
So therefore, your history will probably be from mother or from the
Mother, sir.
mother.
Yes, sir.
Have you inquired whether the child was diagnosed with cyanosis at birth?
No, sir. The child was not diagnosed with cyanosis at birth. It was a hospital delivery. The mother said that she did not notice any cyanosis till the child had cold and fever, and there was cyanosis, and they took the child to the doctor, sir, at 2 years of age.
And then it was diagnosed?
Yes, sir.
Okay. See.
Okay, go on.
Sir, at 2 years of age, the child had cold and cough. Along with that, the mother noticed bluish discoloration of the cyanosis of the fingertips, and he was taken to the doctor, where it was diagnosed with a heart. There's a hole in the heart, according to the mother, and they said that it will get treated by medication. So what medication was going on at that point, they did not know. They said around 2 tablets they were giving, sir. After that, sir, but the child did not improve, and at 3 years of age, the child would have easy fatigability when they were playing and could play less than his counterparts, sir. And the child developed a habit of sitting down whenever he would get breathless, or would the cyanosis will deepen, sir. At age of 8 years, the child has started having even more cyanosis at climbing of the stairs, and it started becoming worse. At that point, they consulted another doctor who said that the treatment for this will be required surgery, but they refused surgery at that point, sir. Finally, they agreed for surgery 3 months back when they first presented to our hospital, sir, at 14 years of age, sir.
Okay. What is that child sitting and what is that?
Sir, squatting position, sir.
What is squatting?
Sir, squatting will be, sir, a way for the child, for the TET spell to terminate, sir, by kinking of the femoral arteries.
Bringing knees close to the abdomen.
What is squatting?
Sitting down with.
I am not asking you how squatting relieves the symptoms.
Sir, bringing the knees close to the body and holding the knees close to the abdominal viscera, sir.
Okay. Somebody else.
Bringing the knees close to the chest, sir.
Okay. Squatting, again, have a perfect definition for that, so that examiner will not ask any other question.
Flexion of the
It
hips
is
and knees.
instinctive. Okay.
Squatting is flexion of the knees and the hips with the thighs opposed closely to the chest.
Okay.
Sitting in the Indian toilet, looking like that.
So it is the instinctive posture the child assumes on exertion when it is fatigued, wherein the child draws the flexus at hip and the knee, and with the help of the hands draws the thigh to the abdomen, which relieves its fatigue. That is the squatting. And then why squatting relieves and all. What does the squatting tell you? If you have elicited the history of squatting, what is the diagnosis?
Tough physiology.
Aste, tough physiology. Did the patient have spell?
Sir, no history of spell where there was deepening of cyanosis and the mother noticed syncope or
Question
seizure.
is, did the baby have a spell? No.
Another thing I just
Don't expand on.
wanted to make a point. See, there are two types of examiners. One who wants those sentences told in the words of the patient, but many of the examiners in MCH and DNB would be happy if you were to give the technical term and finish it off, because we want to go to surgery. We are not a cardiology exam. You have to read the mind of the examiner what they want. For example, Dr. O.P. Yadav, if he's the examiner, he wants it as words as told by the patient. But 99% of us want just the summary. So please tell it that way.
Okay. Okay. So then there will be a question on what is a spell. So read it. Okay. What is a spell and how to treat a spell? Remember, if the patient has got spell, the diagnosis is only three: TOF physiology, tricuspid atresia, pulmonary atresia. If there is a squatting, the diagnosis boils down to tetraphysiology. Okay, go on.
The child had no episodes of hemoptysis, seizure, syncope, no episodes of polycythemia where the patient noticed headache, seizures, fever, knee joint, abdominal pain, no failure-related symptoms, sir.
No failure-related symptoms meaning?
Sir, no history of pedal edema, no history of getting admission after a prolonged episode of LRTI, no episodes of puffiness of face and eyelids, sir.
Okay. No history,
Yes,
which
sir.
is far more common in a tetralogy of fellow.
Sir, polycythemia is more.
One is, you said seizures.
Yes, sir.
Anything else far more common in tetralogy as compared to congestive cardiac failure? Infective endocarditis. So that should, so there are standard 4 or 5 cardiac complications, but it is your intelligence to tell them in an appropriate order. If this is a case of mitral stenosis, congestive cardiac failure will be told first, and infective endocarditis last or not told. In tetralogy fellow case, what should be first?
Infective endocarditis.
Understand? Rather than spending time on And Prasanna sir has already told you, either you tell the gist or tell in detail. So after telling gist, don't keep on spending time in telling the detail. Let the examiner ask you, what did you ask? That time you tell.
And also you're using the word polycythemia in the wrong place. Because you used polycythemia 3 times without having any relevance to what you're saying. So polycythemia itself will take you to another viva. What are the features of polycythemia and what is happening?
Sir, headaches will be present.
Yeah, so you could have mentioned
Yes,
that rather than saying polycythemia in your talking, no?
okay. Past history, no history of admission, no history of surgery, birth history. The child is the sixth
In
child.
the modern era, along with surgery, what you should add? Procedures, interventions. Okay. So you should quickly know. And as I always tell all the students in the practical exam, please don't try to give 24 causes. Just try to tell quickly the most common 1 or 2 causes. Okay. So what are the, can you tell me quickly what interventions can be done in tetralogy?
So CAT study could have been done for that patient.
Intervention.
Sir, stenting of the PDA.
Okay.
RVOT stenting, sir.
And
Pulmonary valvotomy.
okay, thank you. So be quick and answer.
Birth history. The child is the sixth sibling of a non-consanguineous marriage with 5 older siblings. He was full delivery of full term at hospital at 9 months.
You are giving a full toss to examiner to ask what are the chance of sibling getting tetralogy of fellow. Just be aware. This is a full toss.
Yes.
You are telling the examiner, "Aap bail mujhe maar."
What is the inheritance they'll ask you now of this?
Now just be aware.
Yes.
Okay.
Yes.
Those are the
Aware, you say?
Sir, 10%, sir.
10% is the answer to be given when you don't know the answer.
Meaning 10% mean if you're born with TOF, you'll have your child TOF or your second child will be TOF. What is this 10%?
Sir, if we are born with TOF, the child inheriting TOF, sir, and same.
TOF, he can't inherit TOF. He's got TOF.
No, 6 siblings. First is TOF. So what is the chance of second, third, fourth being TOF?
3%. 3%.
That's what you have to go and read.
Yes,
and if you are born TOF and if you're giving birth to a child, what is the incidence of your child having a TOF? That is what we are asking. So better is to stay away from that thing in the exam.
Student, I will say birth history not relevant to the present illness.
Just avoid it.
You are taken, keep it
Yes, sir.
quiet.
Okay.
This is the absolute full toss. Huh? Telling examiner, ask me about that. And if you utter the word, auntie also had or uncle also had TOF, then you had it.
Maternal history, non-significant to the.
Okay, quick line, ma'am.
To summarize, he's a 14-year-old male presenting with central cyanosis with easy fatigability, with history of cyanosis spells that used to terminate with squatting, currently not that much. And
Currently, not that much are all loose statements. Is he having?
No, sir, no
Then why
TED
do you say
spell.
currently
Okay,
not
sir.
that much.
So you don't pass that much and you fail this much, then
Okay.
Fatigability quickly, similar to dyspnea. Can the person do indoor activity? Living activity?
Yes, sir.
Can the person go to school, college?
Yes, sir.
Can play or not?
No, not that much, sir.
Quickly
Yes,
tell
sir.
accordingly.
Yes, sir.
At 14 years of age, you can tell NYHA because one of the components of NYHA is fatigue. So you should have been able, if it is a small baby, it is something different. What is the score for a small baby? If it's a small baby, what is the score that is used? ROS score is used. And for an adult, you can, I mean, once they can communicate with you and do this thing, it is NY.
One common mistakes most of the students do is confuse dyspnea with fatigue. Dyspnea is a condition where you get an increased pulmonary blood flow situations, whereas fatigue is happening in the decreased pulmonary blood flow. So when you talk about the history, be very careful in what terminology you use.
To summarize,
So what is your diagnosis in your mind
sir, top
in this
physiology.
case?
Sir, top physiology.
And what is likely to be absent in this case? Along with TOF, something at the age of 14 years is likely to be absent. Complications of TOF, like associated things like
infective endocarditis will not be there, sir.
Why the infective endocarditis not to be there?
no history.
No history, sir.
Okay.
No history, sir. Sir, at his age, there's no, he's not, we'll have to examine further for valvular
Unlikely
incompetence.
this patient has got associated AR,
Valvular incompetence,
PR,
yes, sir.
unlikely.
Yes, sir.
Looking at the story. Okay.
You have to be a little bit more eloquent about the cyanosis. You only qualified it as central cyanosis, but you need to say when was the first cyanosis noticed, means, or you can say cyanosis was detected late, which means a lot of differential diagnosis goes out of the window. So that needs to be emphasized.
Examination.
So if cyanosis was a week after the birth, what are the conditions that you would think about?
TAPVC?
TAPVC. TAPVC.
At 1 week away, you should use some other qualifier for TAPVC.
Unobstructed.
Is that the first one that you will come to?
If you say I'm unobstructed, then the only answer, if I say it will be obstructed. No?
And TAPVC is cyanotic at birth or later? Because it's a mixing lesion. It's not reduced pulmonary blood flow. What you are talking about is if at 1 week you are having a child presenting, usually that is the time when the duct starts to close. So you should look at duct dependent lesions which present a little later. 48 hours is when duct starts to close. By 1 week, generally most of them are closed, or they may be starting to close at that time. So you need to look at duct dependent lesions in the first week. Then in the second week onwards, usually for tetralogy of Fallot, it is in the 3rd week or later that you get cyanosis.
Incidentally, because we are in India and the National Health Program has started this, you should all know what is the hyperoxia test, because it is now considered mandatory in every PHC that a hyperoxia test is done by the DAI. What is
hyperoxia?
Sir, we check the right radial PO2s from the right radial artery. They give the child oxygen for 5 to 10 minutes and then recheck the radial artery saturation, sir.
Saturation. And then?
Sir, if it is around 160, sir.
No. Saturation is 160, yeah. You know, you don't know. If you don't know, see, this is what Hiremath told. If you don't know, it is far better to tell I don't know rather than to say 160. All DIs are supposed to do this test because they want their patients to be referred to the tertiary care center. With wide availability of pulse oximeter today, all DIs are being given. You know who a DI is, no? The midwives. They are supposed to do the hyperoxia test at the time of delivery. It's a National Health Mission statement.
So what does hyperoxia do?
It can diagnose between peripheral cyanosis and central cyanosis by giving oxygen. And we can always figure out whether if it is a central cyanosis and if it's a cardiac lesion. So that's why.
What is central cyanosis?
So cyanosis because of mixing
Deoxygenated blood in aorta.
Thank you.
Just a trick about how you reply to your examiners. You have to say, I don't know, but wait for 3 seconds before you say, I don't know, because otherwise all the questions you will keep on saying, I don't know, I don't know, I don't know. Then you're likely to fail. Wait for 3 seconds to think of an answer. Within 3 seconds, if you don't know, then you say, I don't know. That's a trick.
What else is the problem with giving 100% oxygen to a newborn?
Kenneth, I really give 100% oxygen in the PHC?
That's the point.
Ventilation, sir, we can. Ventilation.
I intubates everybody.
Okay, let us not deviate from the path. Okay.
Can I just chip in with a comment?
Hyperoxemia do?
Dr. Iyer wants.
Dr. Iyer.
Yeah. I think it's not the hyperoxia test which is mandated. It's basically a pulse oximeter reading or peripheral oxygen saturation, because that is convenient to do even at the periphery of the pulse oximeter. And then if the oxygen saturation is low, irrespective of what it is, they're supposed to be referred to a center, where of course it can be followed up with a hyperoxia test. So hyperoxia test will essentially eliminate cyanosis due to a congenital heart disease or peripheral disease like AV malformation or AV shunting from something either related to the lung or a peripheral cyanosis.
What is the mechanism of closure of the duct?
Sir, anatomical and physiological, it will happen, sir. So duct closure can happen because of the prostaglandins that are being secreted after birth. That can lead to narrowing.
Prostaglandins?
Secreted after birth?
No, maternal prostaglandins, sir.
No, what happens actually, tell us?
Sir, they come down, sir. So the ducts start to get closed, sir.
How does it come down?
Sir, because after birth, sir, they are not, sir, maternal prostaglandins, sir.
Maternal means where does the mother produce?
Sir, placenta.
Then say that the
Yes, sir,
placenta is
placenta,
gone,
sir.
so the placenta is no longer there, so the
Yes, sir.
prostaglandin is not come. Why you're taking such a long time? Okay, then.
One of the other things is oxygen.
Second thing is?
Oxygen.
Oh.
Yes. You go ahead, sir.
Go ahead.
Yes, sir. So once the patient takes the full breath, sir, that can also lead to closure of trigger of the closure of the ducts.
So if you increase the oxygen, most of the duct dependent lesions will come to the fore. That was the point that I was trying to make.
Your answer should have started with giving oxygen results in ductal closure.
So Aparajita, you are with history. So at the end of the history, what was your diagnosis?
The top physiology.
Top physiology. Okay. What is top physiology?
Sir, reduced blood flow to the pulmonary valves, pulmonary vasculature, and with a large VSD causing mixing of blood, sir.
Thank you. The next guy. Yeah. Yeah.
Okay, coming to general physical examination, patient.
Can I ask one question? Okay. In the history, can you just enumerate the points which favor this is better?
So late presentation of cyanosis.
First of all, patient age of
14 years. Is a
certain patient the age of
14
years
is highly most likely.
Number two,
late presentation of cyanosis. Squatting.
Suggested this tetralogy of Bhat. And what could have been cyanotic spell. Okay.
So what are the cyanotic spell equivalents as age progresses? The beginning, what is a cyanotic spell? You already told, right? So in the beginning, you'll have cyanotic spell. As the child grows, what are the other things which can replace cyanotic spell? One of them, squatting, you said. What are the other?
Loss of consciousness, seizure, sir. The child can have a seizure and then it can terminate, the spell can terminate with that. I don't know.
Anyone else?
Standing cross-legged. One, and second is the child can sit with in namaz position, and then the child can lie prone.
Idea is
to reduce the venous return to the heart.
deoxygenated blood needs to be reduced, come to the heart. Am I right?
How does a 6-month baby who can't sit squat?
So the mother can take hold of the baby and press her thighs against the mother's chest and his own chest, so that
7-month baby comes to the what is call it into the casualty and is having a spell. How will you make the baby squat?
So we can press his thighs against his chest.
Will you be keeping on holding on to it forever?
We can tie.
Cross over the legs and you strap it together and keep it. Yeah.
Sir, you can next one.
Coming to general physical examination, patient is moderately built and moderately nourished, is cooperative, with height of 138 centimeter, weight 26 kgs. Patient is having generalized cyanosis with fluid discolation of fingers and toes. Patient is not having any pallor, icterus, edema, or lymphadenopathy. Patient is having clubbing of grade 2. General vitals, heart rate of 80, regular with no radioradial or radiofemoral delay. Blood pressure of 90/60 with a saturation of 87% in room air.
Your clubbing grading is 6 or 4?
4, sir.
You better say 2/4.
2/4.
What does clubbing tell you?
Hypertrophy of the subungual tissue.
I'm not asking
clinically what
what is the clinical information you get?
Long presenting deoxygenated state.
So this story is true, that late occurrence of cyanosis. Okay?
Okay.
What are the conditions where clubbing doesn't increase to 4/4? Eisenmenger.
I don't know.
Eisenmenger.
Eisenmenger. Okay.
Eisenmenger, you will never get 4/4 clubbing.
Okay.
So typical cardiac cyanosis will always result in this 4/4 clubbing. Then TAPVC, they never have, even TAPVC excessive flow, you will never have 4/4 clubbing.
Okay.
Only very mild clubbing. And other causes of clubbing, like hepatic causes, you will never have 4/4. So severe clubbing not only tells you it is long duration, it also tells you this is cardiac cause of clubbing. Every word you speak tells you wealth of clinical information.
Cardiac or lung?
Tell me a cardiac condition, acyanotic, having clubbing.
Infective endocarditis.
Thank you.
Another trick about this, when you're talking about clubbing or anything like that, be very specific in trying to say what you're trying to say, right? Specific, 2/4. And also, you say 2/4 if you know the answer to the question that is going to follow up. What is the grades of clubbing? Third trick is, I'll tell you the trick later on.
Sorry, go ahead.
Yes. Coming to inspection, The precordium is normal. There's no visible.
Iyer sir, you are quiet and not only silent but quiet also.
Giving a clue, huh?
I'm learning, I said.
Sorry?
I'm learning, I said.
Okay. Clubbing the ideas.
I'm learning a lot.
Yes, sir. The precordium is normal with no visible pulsation or scars.
So what is that called?
Silent precordium. No, but
Silent is hearing, no?
hearing.
Quiet.
Quiet. So this was what I was telling you.
Quiet.
The
What
sounds
are the
of
causes
silence.
of quiet precordium? So don't start looking left upper quadrant. So start from skin, thick chest, pendulous breast, pericardial thickening. Like this, you keep on going inside. What are the cardiac chambers which make the precordium active? If you know that, you know what are the causes of quiet precordium.
LA and RV enlargement.
LA. You said LA?
First is what, man?
RV.
And then next.
Which are the anterior chambers, my dear?
RV, sir.
You are from Jaideva? My God.
So RV, agreed. RV.
RV.
LA is a very specific thing. In this case,
RV.
if you have a Thurstos, you should say.
Anything other thing will make. What are the things after opening the sternum you see in front of the heart? RV.
RV.
Any other chamber you see?
Structure.
Any other structure you see?
RA.
Array. The whole thing has to give pulsation, man.
Pulsation, no? Pulsatile, big.
You must
high pressure.
Third, must give some activity.
Yes.
MPA. Ascending aorta. So these all make precordium active. Or the LV has enlarged and apex has become a very prominent, diffuse, well-sustained apex.
You are mistaking heave for active precordium.
Don't confuse the active precordium means some activity seen over the precordium.
Okay.
So these are the structures. Once you open the sternum, these are the structures which you see. Okay?
Yes. Coming to palpation, the apex beat is palpable at the midclavicular line, just medial to the midclavicular line in the fifth intercostal space. There is no.
So what does it mean hemodynamically to you?
The LV is not enlarged, sir.
Heart is small.
Heart is small.
Chalo, go ahead.
There is no thrill palpable. There is no heave felt, sir. Coming to percussion.
Before thrill, you should say sound. Sound, thrill, in that order you should say.
Okay.
So no palpable heart sound.
Heart sounds.
Okay.
Okay.
And don't keep saying coming to, just talk.
Okay. Percussion, the right heart border corresponds to the right sternal margin and the left heart border corresponds to the.
If you speak nicely so much of percussion, I'm thankful. Start with liver. Okay. Cardiac percussion starts with liver. So liver dullness is on right fifth intercostal space.
Mid-clavicular line.
Like that you have to supposed to start.
Okay.
Why is it significant?
Fasciitis solitis.
And anything else?
Congestive features.
If the liver ptosis, all picture is going to change. So you are trying to tell that liver is in its normal position. Then right heart border. Perfect.
Yes, sir.
So right heart border
corresponds to the right sternal border.
So what does it tell you hemodynamically?
RA is
small. So concurrent with your diagnosis of tetralogy?
Yes, sir.
Yes. Thank you. Every word you speak, you ask yourself, is it concurrent or is it an odd feature?
Okay.
Okay. Go ahead.
It doesn't mean that you will suppress information which is not concurrent with your.
And another trick, whenever you say a word, like as soon as she said cyanosis, he immediately asked a question, what does it mean? So every word you say, in your mind, you have to think, what is it, the interpretation that you are making because of that word that you chose. You make an interpretation. Sternal border is right. What Dr. Tendolkar says, what does it mean? This you have to do your thinking as soon as you say the word. or when you're preparing the case?
Another thing is if you are trying, you're supposed to lead your examiner to a particular direction. So sometimes if there are controversial findings, better to avoid it. Yes, proceed.
Then don't come. You have come, then you stay there. He says he has passed.
On percussion, the left sternal border corresponds to the left apex beats. To the apex, and the pulmonary base dull on percussions. Coming to
Don't say pulmonary bay. By bay, you have already told what is the shape. In our time, there used to be one television serial, Bay Watch. You may be still watching. Looking at your face, looks like you are watching. So don't say bay. You say pulmonary segment.
Okay.
Okay.
On auscultation,
which tetralogy fellow case pulmonary segment will be dull?
All
full, dull.
No, dull.
So
The student is dull.
TGA.
Student who says pulmonary atresia is dull.
TGA is a top physiology.
Tetralogy of
TGA,
fellow.
PSD, PS.
Tetralogy fellow pulmonary segment full.
Huh?
Yeah.
Absent pulmonary.
Thank you. Or PR. After infected endocarditis, PR. Very good. What's your name, boy?
Siddharth.
Siddharth.
Yes.
Good.
Any other condition?
Just a comment. Shouldn't we be?
Iyer wants to say some. Iyer, sir, we can't hear
PA
you.
is dull.
We can't hear you.
Sir, large PD.
And I-
should be there.
TGA, VSD, PS. CCTGA.
Iyer, sir.
LTGAs, where the aorta is in the pulmonary artery position.
So please go ahead.
Go ahead.
Yes, sir.
Dr. Iyer wants to make a comment.
Yeah, just a comment. I said, shouldn't we be focusing with these candidates more on investigation than line of treatment rather than physical examination and history? Because I think what they need
Dr.
to know
Iyer,
more.
in this is the first cyanotic case. They have got another cyanotic heart case. We are supposed to examine them on the presentation, summarizing the history, clinical examination, clinical correlation, complete diagnosis, justification of diagnosis, relevant investigations and findings.
Yeah, I thought this 1 hour
And the
was for
body
the entire-
language, ethics and behavior.
Right.
In the second segment, I think the surgical aspect of it.
Okay.
Right. Sorry, I didn't know there was a second. I thought
On
this whole 1 hour was.
auscultation, S1 is present in all areas, normal. S2 is single. There is a ejection systolic murmur of
S2 is single and formed by
A2.
A2 component.
A2 component.
That should be absolutely.
One sentence.
And you need not say S1 is heard in all area. There are again two ways of describing auscultation. One way, which you are talking just now, is the best of the picture. Okay? Just like coronary narrowing, you say 80% means the best of the picture is 80%, like that. So S1 is normal, S2 is single and formed by P2 component. Sorry, A2 component.
Yes. There's an ejection systolic murmur heard at the left upper sternal border at the pulmonary area. There are no other murmurs in the
So
back.
why say upper sternal border when you are saying pulmonary area?
Okay. Only pulmonary area, left sternal.
Okay.
You said no other murmurs. Now, what is this no other murmurs?
Sir, if there are other collaterals present, murmurs are heard on the back.
Famous collateral whose murmur is heard.
PDA, sir.
So why not start with PDA?
Yes.
And precordial auscultation, no?
Yes.
So outer pulmonary collaterals are heard on precordial auscultation. Will not be.
Yes.
Okay. What is the relation of the murmur and severity of tetrad?
The duration of murmur is inversely.
See, Seetharama Bhat sir just now told behavior of the student. So these are absolutely basic questions. for which if you turn your eyeballs, left upper quadrant doesn't speak good. Okay?
Okay.
So RV has got two outlets.
Yes.
So if one outlet is narrow and the other non-restrictive outlet, RV will pump blood through
VSD.
to the VSD.
Yes.
So what will be the murmur as the severity becomes more and more severe?
Shorter.
Shorter and softer.
Softer.
So remember, see, inversely proportional.
Inversely.
What happens to the murmur in spell?
Murmur becomes close to absence, sir, because of infundibular spasm.
Very good. Now you told murmur is heard in P2 area. What does it tell you hemodynamically or pathologically?
There is a significant stenosis in the.
So where is the stenosis exact?
In the RVOT, sir. Can
RVOT is not one dot, man.
In the infundibular.
P2, you specifically said
P2.
heard in upper sternal area P2. So what kind of obstruction this must be?
Valvular.
Common in tetrad?
No.
Annular.
Annual.
This case likely to be annular obstruction or subpulmonic obstruction plus valvular obstruction. Okay?
Okay.
If you had heard it low down, fourth space would have been os infundibular. So the place of the murmur also tells you the pathological position of the murmur. Okay?
So you can actually say ejection systolic murmur heard in second left intercostal space and third left intercostal space on the left side to say where it is best heard. From there, you can make a diagnosis of where the obstruction is also. Instead of saying P2, you are committed to only one space. That means you are not saying anything else.
Okay, go on.
Examination of the rest of the systems were normal. Coming to a provisional diagnosis is likely.
Just can
Back and the axle. In the interscapular region, will auscultate.
How do you make it? I'm the patient. How do you instruct me? He's instructing me.
Can you keep your hands like this? I'd like to auscultate.
You're supposed to
Bend.
bend. Across.
Yeah.
So what are you trying to achieve? The distance by bending and forward.
String of the
distance between the skin and the collateral. You're trying to decrease. By crossing the, you're trying to take the
scapula away.
And muscles flatten. All this you should be able to pay.
before you go to diagnosis or this one, always summarize. Now that you have completed examination and the history, please summarize in a few sentences before you go to diagnosis.
14-year-old male presenting with cyanosis and easy fatigability since
with central
cyanosis and easy fatigability.
No history of spells.
No history of spells. With history of squatting and with clubbing with sinus.
Clubbing is examination, I mean clinical symptom.
Okay. With
sign. You are now talking about symptoms first, then signs, and then after.
14-year-old boy with central cyanosis, with easy fatigability since 10 years, with history of squatting, with no spells, with the ejection systolic murmur in the pulmonary area, likely patient to be in a TOF physiology, likely diagnosis to be TOF, not in failure or with presenting with the failure or infective endocarditis.
When do you get failure in tetralogy of Fallot?
If patient also has AR.
You said no failure.
No failure.
You're talking about, obviously about cardiac failure. So when do you get?
Patient also has AR.
AR. Okay.
Causes of failure in TOF is anemia, infective endocarditis, then PR, there is severe PR, severe AR, MAPCAS, and adult of restrictive VSD.
What are the causes of restrictive VSD in TOF?
Diagnosis.
Sir, you would like to ask anything?
I was asking what are the causes of restrictive VSD in tetralogy of alone?
What is the causes of
Tricuspid valve restricting the VSD or aortic valve restricting the VSDs?
So what is that known as? Tricuspid valve restricting the VSD. What is that?
RCC prolapse.
Does it have a name?
Something.
Tricuspid valve blocking the VSD.
Lapping septal.
Have you heard of Hoffman syndrome? It's a specific entity. You read Kirkling, where the tricuspid valve is attached along the margins of the VSD and restricts the VSDs. So these patients have suprasystemic RV pressure.
Okay, so your diagnosis is TOF physiology, tetralogy of fallow is your first. What are the other differentials?
DORV VSDPS, DORV VSDPS.
Okay.
And
Which type of DOR?
not sure. DOR.
What are the types of DOR? What is DOR?
Types are doubly committed, non-committed,
Symbiotic, subpulmonary, doubly
non-committed.
So out of these four, which will be indistinguishable from
Subaortic, subaortic.
Or TOF type of DOR.
So DORV, VSDPS, then what else?
CCTGA, VSDPS.
Okay.
CCTGA VSD is
Which-
commonest in which sites?
Right answer.
Situs inversus totalis or situs solitus dextrocardia or situs solitus levocardia or situs inversus levocardia. This is your MCH entrance exam. Entrance exam question. Yeah. Commonest congenital cardiac anomaly in situs solitus dextrocardia is the question. Is?
CCTGA.
Okay. Yeah.
Speak into the mic. It's all going to be recorded and people outside are listening to it. Speak into the mic.
Situs solitus dextrocardia.
Okay. Then single ventricle PS.
Single.
Is it possible?
Yes.
Huh?
At this 14 years of age.
What is the survival of single ventricle PS at 1 year? It is not that bad. It will be something like
30%.
It is
30%.
something like 50-60%. What is the survival of tetra at 1 year?
So 75%.
Survival at 1 year.
75%.
75%.
Yes, sir.
Survival at 3 years?
50%.
Survival at 10 years?
25%.
Yeah. Okay. Then what is the other diagnosis? Tetraphysiology? TGA VSDPS.
TGA VSDPS.
Would it be TGA VSDPS? Very unlikely to survive. What is the survival of a TGA VSDPS?
10%.
At 1 year?
10%.
If it is a 1-year-old child, how will you say it is not TGA VSDPS? If child who is 1 year, blue, tetralogy, physiology are saying, but what is the differentiating feature?
So justification of diagnosis is over.
Spell. They don't get spells. It is gold medal if you tell how a TGA VSDPS.
Investigation, sir.
Now, relevant investigations and the findings in the investigation. Next.
For a 14-year-old tetrad.
I'd like to investigate. I would like to investigate the child with the chest X-ray first.
Why do you want to investigate this child?
First, to confirm the diagnosis, then to understand the severity of the disease and plan for surgery.
Why do you plan surgery?
To increase the quality and the quantity of, to alter the natural history of the disease. I'd like to get the X-ray done for the patient.
ECG. There is ECG on the screen. Yeah. One X-ray.
Okay.
So X-ray is well exposed PA view, centralized with situs solitus, levocardia CT ratio of 0.5. RA is not dilated, and aortic knuckle is prominent.
Where is the aortic knuckle prominent? Point it out, please. Can somebody give him a pointer?
No, you can look, I mean, you can use the
cursor.
You can use the cursor on the screen.
Do you have control there? Because it will put up from here, Jagannath.
Where is the knuckle? Where do you look for knuckle?
Go there. Go there here.
You said knuckle is prominent.
Is it really there?
No. This
When do you call aortic knuckle as prominent? You're showing it in the right place.
Is there a bump there?
When there is a bump, there is no bump.
Okay.
It's not there. Then
Left side aortic knuckle is there, not there. So where should it be?
Right arch.
Right side. If it's not there on the left side, it has to be on the right side. Okay, then. When do you get a right side aortic knuckle?
Right arch.
Right
arch.
What is the incidence of right aortic arch in tetra?
30%.
Which congenital heart disease is the maximum right side aortic arch? No.
Truncus arterius.
Truncus 30%, tetra 25%. Okay. No. What is the first branch of the arch in a right side aortic arch?
The branching pattern is called mirror image branching pattern. Mirror image. So first branch will be.
He said, Dr. Tendolkar, this is the question I asked in the examination, and I got the answer as left subclavian artery. That's why I'm asking this question. Which is the first branch of the arch in the right side?
So no, it's a mirror image. So in the right aortic arch, first branch will be innominate. But innominate this will form what? Not the right subclavian.
Left common carotid and left subclavian.
Left common. That's right.
The right common carotid and
then very low incidence of this is second branching pattern when you get 4 branches taking origin in right aortic arch.
So which is the fourth branch?
Where the first branch is left subclavian.
Which is the fourth branch?
Left subclavian artery. Left subclavian artery is the fourth branch.
If the first branch is left common carotid, then is something like the dysphagia, lysoria, the substrate.
Is this rotated fill?
No.
Is that shadow in the upper heart,
20.
aorta, or some other structure? You are all students going to appear for exams? Then you have to sit on that side.
The great divide.
Train was late? Sorry?
Bus.
Bus was late. From? Chennai? Ratri ki varliya? Car talo vandacha?
I'll tell that is thymus or SVC.
Quick.
Why not?
Thymus and SVC are what called? Cervicothoracic sign. So can you trace that soft tissues Shadow
into the
above
neck.
the clavicle?
Mm,
Yes, no.
yes, sir.
Yes, so likely to be thymus or SVC.
SVC.
Points against thymus?
If it is below the
Age of the patient?
14 years.
So 14 year you expect
No,
a large
Thymus
thymus?
to be that
no.
big.
Unlikely.
Unlike.
Okay.
Can it be a right aortic arch?
Yes, sir.
We cannot see the knuckle on the horizon.
Can you
What do
see
you
the
define as a knuckle? The shape. That's it.
It's a bum.
So you look at it, you put your knuckle over there, you can see. You're expecting the knuckle to be on this side. It is on this side. That's all.
All you have to see is the tracheal indentation. If the tracheal indentation is there, that is the aorta and cervicothoracic sign. Another thing that is pointing there is if you see the intersection between the RA and the silhouette of the RA versus this, okay? You can see the descending thoracic aorta shifting over to the right here. Okay.
In a right side aortic arch, when does the descending thoracic aorta after the left side?
If they had caught the clue. If they had caught the clue.
Does it go down like that?
Is it on the left side of the hiatus, right side of the hiatus?
Right
Where
side.
does it go?
Left side.
Can
The
we have
left side of the
X-ray again?
hiatus.
X-ray please.
X-ray, please.
In a congenital heart disease, what else you will not forget to report
Yes.
apart from R?
Branch PS, pulmonary artery
Lung
vasculature.
fields.
Lung fields.
Hypooligemic,
Oligemic.
normal, hyperemic. You have to opine.
And specifically in a tetralogy of fellow, why will at 14 years of age, what will you be looking at the lung fields, which will have a impact on your surgery?
Collaterals.
Huh?
Collaterals will be.
You really can see the, how will you see the collaterals as you said?
So rib notching. will
Rib notching, really?
Rib notching.
Rib notching, really? In a tetralogy, you will get rib notching. Okay, in a tetralogy, when do you get rib notching in an X-ray? Now, in 2024, do you get 2025, I have to say, do you really get in early 1900s? Yes, maybe, but today, no.
No, sir. You can't get rib notching.
Yeah, why did I say in early 1900s you could get a rib notching and not today?
Not sure.
What was the operation done for tetralogy in early 1900s?
BT
What BT shunt?
Classic.
Classic BT
BT
shunt.
shunt.
So when the subclavian
When
used to
I
be
get
brought down, then you could get.
the ring
But otherwise, tetralogy does not
Okay.
give rise to coarctation.
coarctation.
Never.
It's not feasible.
Has this patient undergone? Don't look there now. Has this patient undergone left BT shunt?
Left BT shunt. Yes,
No,
no.
On X-ray.
On X-ray.
Don't look there. I'm looking at your eyes. I'm staring at your eyes.
It's a 50% question answer. You have to say either yes or no. Can't say both.
No.
And after having said yes, you can't say no.
Or half of you can say yes, half of you can say no.
Then you
No, sir.
No, because on X-ray, because
You see the radio.
So there is no crowding of the ribs on the left side.
so he said radio
What
opaque.
radio opaque?
Radio opaque.
Sorry.
What?
What?
Sorry.
When you said radio opaque, everybody's ears went up like a cat.
That is not safe.
Siddharth, correct. Siddharth, you are past MCH or
So I'm going to appear.
going to appear? Excellent. So you'll see rib
Rib
notch,
notch.
rib crowding,
Crowding.
rib fracture, rib callus,
Plural.
synostosis,
Plural reaction.
pleural reaction. Not
No.
radio. Aisa, remember, exam is snake and ladder game. You know snake and ladder game? Sap and CD. You understand Hindi or?
Hindi
You
and
are from
Marathi
United
बोल
States of
सकता है.
Tamil Nadu.
Marathi.
Maharashtra.
Maharashtra.
Marathi.
Sap CD
Yeah.
माहिती है ना?
We have got
So
another
such
10 minutes.
nonsensical answers will
10 minutes.
take you to bottom.
10 minutes.
Okay?
Okay.
Chalo, ECG.
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 You have the ECG, please. ECG, yeah.
Okay.
What are you looking for?
I wanted to ask them, does the left side look less perfused, lungs, in the X-ray? It looked less perfused. What does that suggest to you?
The left
If there is a hyperperfusion on one side and more perfusion on the other side, what does that suggest to you in a tetra?
Stenosis of the LPA branch LPA. LPA or distal branch PS on the left side.
Yes, LPA stenosis.
Stenosis.
Or
Now-
one-sided shunt.
Single-
One-sided shunt. Okay?
Ah,
ECG.
ECG.
Concurrent with your diagnosis
Yes, sir.
because
There is sudden transition of R wave.
The sudden transition.
In V1, R wave is tall with.
There is no sudden transition.
There is no transition. It's a
The transition is occurring at V3. There is nothing sudden there. See, all of you are telling sudden, sudden. Where is the sudden? I'm still having an R wave there. Nice R wave in V2. V1 is positive. V2 is
V3 and V4 are almost
V3
similar.
transition is occurring at V3, V4. I mean,
Deep S wave in V2, sir.
V2 is there. It's not a sudden transition. It is becoming equiphasic there and then becoming the transition.
Transition is when the R wave and S wave are equivalent. That's the
What-
place where you.
what is the axis?
Uh,
Read, calculate and tell.
extreme right axis deviation.
What is the significance of your axis in this diagram?
What is the axis in a tetrad?
Mild right axis deviation.
How much? Allowed up to what?
Plus,
Plus 135. Why? Because of equal hypertrophy of
hypertrophy,
RV and LV. So if you see more than 135, it is not straightforward tetralogy of fallow. Okay?
Yes.
So just please be aware. Then peak P waves, what do they tell? Hemodynamics. This is how we used to
Dilated
judge patient
dilated.
hemodynamics.
RA
Peak
is,
P wave,
RA is dilated.
RA is dilated. Why?
Manje,
The RA is
He asking you in Marathi, huh, by the way.
Okay, if you were
dilated
asked,
RA in top.
if you were asked for one investigation, which investigation would that be?
So ECG over or in the ECG? Okay. P wave tell you RVEDP.
RVEDP.
Okay.
Yes.
So RVEDP goes up, P
The
waves
wave
will
will be
become.
tall.
Is it good or
Because
bad?
we are running out of time.
Yes.
Next
Chalo.
investigation,
Echo.
after the X-ray and the ECG, what they do?
2D echoes, sir.
2D.
You want a 2D echo.
Yes,
As a
sir.
surgeon, what you want to know?
I want to know the area of where the obstruction is at the RVOT pulmonary annulus. What is the size of the pulmonary annulus,
You should
MPA,
ask for,
RPA?
you should ask to see what you will not see on the table.
Yes.
So what things you will not see on table?
The
Suddenly silence.
Branch P, branch.
Sorry?
So,
Branch pulmonary
Yeah.
arteries. Then collaterals. Okay?
collaterals.
So remember, things which are not seen on table, you try to see on investigation.
Investigation.
So we come back to
Additional
which-
VSDs. Remember, additional VSDs.
Yes.
Additional VSDs, distal pulmonary arteries, branch pulmonary arteries. First of all, is this case for intracardiac repair
Repair
or
of
shunt?
shunt.
Dr. Iyer, who is sitting just now, is blanked out. His very favorite question is, what will you counsel the relatives?
Yes. What is the fate of my child before surgery?
They want to know what are the chances, good points, bad points. So all these questions you have to prepare from investigation.
Yes.
Forget tetralogy fellow. Over now.
Yes.
Now you want to go beyond that.
I would like to look at the pulmonary annulus and the pulmonary valve to know if tap will be required. Pulmonary
Say transannular patch.
transannular patch is
So
required.
what do you think?
Z score -3, yes, sir. Transannular patch will be required for this patient. So the fate of the child with the transannular patch, generally they require another surgery and long-term complications are higher in the patients with the transannular patch.
In 2025, with that Z score of -3.7, how will it change your operation in your hospital? In your hospital, I'm asking very quick, pointed question. 14-year-old boy with an annulus of 11 in your hospital.
Valved homograft, if it is
You would
available.
think of
we can
placing
use
a
valve
homograft. Okay.
Yes.
Next, investigation.
Just putting a homograft avoids a future surgery?
No, sir.
No.
Should not.
What is the reason for putting the homograft now? This child is fated for multiple surgery once having a transaction.
Yes, sir.
Why would you think of putting a homograft in a 14 or a 15 or a 16-year-old boy now?
To preserve the valve.
No, you're not. You're destroyed. You're putting up a homograph.
By the way, what is Z-score, please?
Z-score, to know the normal standard deviation according to the height and weight of the patient. Standard deviation from the normal branch, normal
Standard deviation
from the normal values of the pulmonary of the normal population with the same the mean population deviation.
number of standard deviations that the observation varies from the mean normal accepted for that particular age and weight. Very simple.
So you
Okay,
know how
this
to
is
read this chart.
definition. In general parlance, what does that minus 3.7 convey to you?
If there is severe.
The patient has values of less than 3 standard deviations from the mean of that age and.
So you know how to read this chart and come to minus 3.7, I assume. Or you don't know?
Yes, sir. Does. Yes, sir.
Yes, sir.
Okay.
Yes, sir.
What chart is it?
What do you use in your hospital? What do you use in your hospital?
Yeah. Rowletts chart.
Today, you don't, you mean for getting the Z, you don't get the Rowlett chart. What
No.
do you use? What
No,
the
sir.
software? You say that you use
Parameters.
parameters or whatever you want. Okay, but you tell that the Rowlett chart gives you the minimum acceptable.
So what does minus 3.7 tell you? What is accepted
If it is
for
less
a
than
surgical correction?
less than -2 standard deviation is the indication to for augmentation of the
-2.
More than -2. If the standard deviation is more than -2.
Don't confuse the
Don't
issue.
say Z score.
Z score more than -2.
To give him an example and ask him to calculate Z-score.
That's what I'm telling you.
Yes, sir.
Minus 3.7 is your Z-score over here.
Yes, sir.
What will you do?
Yes.
I'd like to put a
Transannular
patch for
patch.
this patient, sir.
What is accepted nowadays? Because valve preservation technology, is the norm these days.
Yes.
So therefore, up to what value you can accept?
-2. -2.
Which
book are you following?
Which textbook? Because Kirkland, I'm sure, doesn't say -2. Anybody?
Sir, -2 to -7, I think.
-2 to?
-7, between -2 and -7.
That is the range at which it goes for surgical correction.
-7 now.
-7.
Where did you read up to -7?
No. No. Prasanna, he's saying that from that range to that range, you can subject for corrective surgery. Am I right?
Yes.
No, annulus atresia, where is that? It is -infinity. But you still operate for the annulus.
Valve preservation.
Please remember, we are not talking of branch PA. We are talking of annulus here.
Correct, exactly.
You are making a mistake there.
So up to -3 is acceptable for correction using valve preservation. You can go beyond that when you are using other augmentation methods. Up to -7, you can go with a transannular patch. But beyond that, you may have to use a condio. That is basically what you were trying to say. Wasn't it? All right. Okay. So -3, some centers even go up to -3.5.
What is Magnus ratio?
Magnus ratio is diameter of the RPA and the LPA divided by the diameter of the DTA at the level.
Better. Qualify it better.
RPA plus LPA.
When? Where? At what
At
phase?
which level?
Where?
Descending aorta at which level?
At the level of diaphragm, descending
And
aorta.
what about RP-LPA? Where?
Just at the
branching.
Pre-branching.
Pre-branching.
In systole or diastole?
Systole.
You want the best possible
Systole.
diameter. Systole.
Systole.
Pre-branching systolic.
RPA plus LPA diameter with DTA diameter at the level of diaphragm.
Each of these should be qualified. Why pre-branching? Why
all,
systolic? Why?
and all should be seen in one frame to avoid magnification error.
But today we are doing it on
Echo.
echo.
So echo also, same view, you should be able to see the descending aorta. Okay.
What is that which you would like to know but is not present over here?
Any coronary is crossing RVOT.
You can look for it. On an echo, you can look for it. You won't get it in echo.
Sorry, sir, question?
Your patient is a 14-year-old child. You had seen differential vascularity in the X-ray. You have got good size branch PAs. LPA, in fact, is showing 15 millimeter where it was.
Yes.
What is it that you want, you're not getting over here?
Distal branch PAs.
Distal,
branch PAs.
yes. What is that called? Arborization.
Arborization.
If there is arborization anomalies, that will not be picked up with echo.
Are you going to operate with this much information?
So will you do CT? Current modern era CT. Dr. Iyer went for case. Many of the institutions regularly do CT in congenital heart. So what advantage, what additional information will it give?
You have a CT for this patient?
Suppose you have, what additional information it will give?
I have one CT, boys want to see.
About the distal branch PAs, arborization.
Distal branch PAs. Number 2.
Coronary crossing RVOT.
3.
Collaterals.
Coming from descending thoracic aorta. 14-year-old patient living, walking around. So must be having large number of collaterals. And going by the stenos murmur, likely to be a very severe tetrad. So must be well compensated by
collaterals.
Collateral. Okay?
Yes,
So remember this. What is the DD of RCA crossing, LAD crossing RVOT? DD on table?
LAD arising from RCA.
Sorry?
LAD arising from
Correct.
RCA.
That is one.
Yes.
Any other DD?
Cone down to the problem.
Conal branch.
Large conal
large
branch.
conal branch.
Are you surprised to find a large conal branch in a tetrad? No.
No, sir.
Why? It is hypertrophied.
Hypertrophied.
Pressure is 110, 120. So require large artery to supply. Okay?
Yes, sir.
Now, what surgery we will do for this patient? Shall we do a BT shunt or shall we do a corrective surgery?
ICRs.
When do you advise a BT shunt?
BT shunt, when there are hypoplastic branch PAs, the arborization is not much and the branch PAs are not developed. So BT shunt.
Hypoplastic pulmonary arteries.
Yes, sir.
Okay. Supposing this patient presents to you at the age of 3 months with the deepening cyanosis, what is the treatment you offer?
First, if this patient with the deepening cyanosis, I would still like to correct with the intracardiac repair if I'm allowed. If it's
You
possible.
tell what is practice in your hospital, please. In your hospital, you can justify that. That in my hospital, this is the policy, not in
Kirkland,
Boston,
not in Kirkland.
Boston Children's Hospital. No.
In practical
your
exam,
hospital.
I shall do, should be the answer.
It's done at 3 months in your hospital.
BT shunt.
BT shunt
So,
exam.
so
At
don't
what-
feel, don't
Nothing
feel,
apologetic about it.
don't feel apologetic about it. Your boss does it, that's why you do it.
At 6
So
months,
simple
what would
answer.
you do if it had presented?
Intracardiac.
Intracardiac. We, in our hospital policy, is at 6 months we will.
Perfect, everybody accepts it. Don't have to tell what Kirkland or Barrett Boys does. You tell what
What
you
are the
do.
indications to do BT shunt in a tetra? At the age of, say, 1 year. 1 minute,
Over.
Manpreet, over is
Over.
it? Okay. So this is the last, your last one. What are the indications to do a BT shunt?
Cyanotic spell if not getting treated with medical
That will
stabilization.
keep it at the last. So
And
one is hypoplastic
hypoplastic
pulmonary arteries. 2, small LV.
LV.
LV of, what is the size?
Less than
Index volume is
30 ml, less than
30 ml.
per
Okay.
meter square.
3, high, yes,
30 ml.
30 ml per meter square. 3, high hematocrit. 4, institutional indication.
So you can divide it into absolute indications and
Okay.
relative indications. The absolute is the first two, which
Hypoplastic
Dr. Bhat
artery.
said, and the others are relative
Relative
Related questions to BT shunt. This patient operated for BT shunt at the age of, say, whatever, X plus 2 years, patient now comes for intracardiac repair. What changes you will see in the investigations and clinical findings? Clinical findings and investigations. Before and 2 years later. By the time sir is telling, you should be ready. You can answer all three together.
Patient will not have any spells, sir.
Patient should
Spells
not
should
have
not-
spells. But can I have worsening of cyanosis?
No.
Can the mother say that his effort has gone down?
Can if the
What is that called?
shunt gets blocked.
What is that? There is one word for it. Sir, this is a time filler. Huh? By the time you are ready.
We have finished.
You are finished.
We have finished our
They
assessment.
are finished. Sometimes when he asks survival, sometimes I wonder whether survival of the patient or the student. He's very favorite of asking survival of tetrad,
So
survival.
there is one more.
Sometimes
There is
I
one
feel
more
this will be
cyanotic
survival
case.
You.
Can you tell us how you are scoring? I mean, for each question, are you scoring or are you?
No. See, we have been given.
Oi, Anuprita, kya Prita?
Aparajita.
Aparajita. So will the VSD be different? Change in size? No.
No.
Then what will happen to RVOT? Become more severe. MP annulus.
Will be
Like that you go on tracing.
Yes.
What will happen to hemoglobin? Decrease. So like this, you don't start looking up and down. Pathology remains the same. Ways of describing will change. So now same thing you have to tell in ECG what will happen. Same thing you have to tell in X-ray what will happen. In echo what will happen. So if you know the pathology, ECG will be the voltage, X-ray are the shadows, and LV echo is the chamber dimensions. Understand?
Yes.
So I also not by-hearted it. So just know the pathological changes and you go on answering. Okay? Chalo.
Next year.
ये क्या तुम्हारा verdict? Due to strong intervention from the HOD of
Okay.
strong intervention of HOD of Jaydeva, they have passed.
Farmer.
What?
Present HOD is here only.
Both strong.
Okay. It is painful to fail the students, always painful. Though, so that painful aspect I have given to Jagannath. So Jagannath has failed. I have passed all. Okay. The painful part is his. But to sum up your performance, what my thinking. See, take it from me. Though you end up as doing MICS surgeons or bypass surgeons, you have to go through this ritual of facing, and your chances of facing a tetra case in the examination is 50%. 50%. 50% of you get 50%. In the short case, okay, it's going through it is 100%, okay, not 50%. Though you do not practice it subsequently, probably the surgical steps you have told is the last time you have ever heard in your lifetime as a cardiac surgeon. But then you have to go through this ritual. So be well prepared for your examination with your definitions, with your answers, that it has to be crisp. I should convey convey what you are thinking, you know, and in tetra, we examine you about the basic concept of the disease, whether you have got it, the surgical, what I would say, the timing of surgery, what surgery, the goal of surgery, the long-term, the result of surgery, and how, what do you want to convey to the patient's family. So we examine whether you have developed those concepts. And for this, your clinical examination, your history taking, clinical examination, relevant investigations, that contributes to for all these things. So our idea is to see whether you have that basic knowledge. Okay. Now coming to your performance, Aparajita's presentation was fine. Aparajita's name I know because she was working in my unit.
Abhishek,
two,
sir.
huh? Abhishek and
Pratik, sir.
Abhishek,
Pratik, sir.
Pratik.
Yes.
Yeah. Aparajita has been passed by both Jagannath and me, but Abhishek's performance as justification of the diagnosis is not up to the mark, and body language, ethics and behavior is not up to the mark for Pratik. Okay. That is his assessment. That is how they stand, how they sit. Then somebody sits like this in the examination, or sits like this in the examination. They are not appropriate behavior. Clean shaven, yes, combed. Okay.
Yeah, please come with, don't come with chappal, come with proper shoes. You should be caught on all those things. No, I'm telling you, in general.
Most important, new clothes.
Okay.
Apron, if you have got a white coat, if you have got that covers so many things.
And if you have a beard, trim it. If you have and girls, nicely tie your hair and we want a respectable visit that you look like a consultant.
No.
Confidence in
All that is accepted, and I'm sure most of you will follow it. But what we are looking for is that confidence with which you will talk. The way you formulate your sentences, you cannot keep on saying, it does not give you enough of, weight. Whatever you say, put weight behind it. Stand by your convictions. Make it a point to write down how you are going to present before you actually present. Practice that presentation 2 to 3 times before you go into the hall. Then it becomes fluent. Try to avoid giving the examiner that particular, a handle to get into your presentation. Okay, only then. And please put a little bit of a smile. Please put a little bit of happiness in your this one. Don't look as if you are facing the firing squad. That is what I meant when I said language, body language, and ethics and behavior.
One definite sorry.
Mama dukkam tava dukkam, mama sukham tava sukham. Okay, if you make mama dukkam tava parama sukham, okay, I get
One definite no. One definite no is muttering. That puts off all suggestions.
Can I just take a minute? I want them to give an assessment of how they felt. With the
They will be
Not
always
1
polite
minute.
and say, sir, we have done very badly. I know. Another thing, another thing for next few turns, whole day, next 2 days and other exams, talking something and then start thinking why I said this. That's a very bad sign. Every word you start looking up. Some questions are absolutely full toss. Understand? Remember.
They have already marked you. I am not likely to come for examination for you people. So feel free to tell negative. Yeah, Aparajita.
What did you not like about this presentation?
I should be more prepared, sir.
She did not like, huh?
I should be more prepared, sir.
Yes, answer.
From preparing more time duration, work. Prasanna sir. Prasanna sir will be always like a
He is working.
joker in the back of car. Anything less, you always put Prasanna sir.
So next time you say, Pratik, when you say, speak very specific, don't do generalization.
Yes.
You know SWOT analysis, strengths, weaknesses.
Yes.
So you tell about your partners, what were their weaknesses? Not about yourself, but about your partners.
Felt the
They will
weakness
not say
with
anything.
all three of us was the presentation, the way we speak. We don't formulate the sentence first in our mind and speak. That
What
is
else?
the biggest problem.
What
And even if we know certain answers, but leading examiner to those questions, to the
You're not done.
answers which
Very
we
good.
know,
What
that
else?
is the thing which we have to learn better, sir.
Why didn't you look at it and speak from it?
No. He's giving feedback.
Another thing that you should always remember is please look at your internal examiner's face. Please look at the internal examiner's face. Eyebrows. And if I'm saying like this, and sometimes, we may be telling like this means shut up.
Prasanna Kumarji, sir, this
No,
is
it
not
is a
work for
very-
DrNB because DrNB there is no internal exam.
No internal, but
So
see,
what do you
whoever
do?
is the convener, when I conduct the DNB exam, I consider myself as the internal. And no, they may not come, but I will consider my students. I mean, I will consider generally as my students, and I do it. That is how I do it. At least I don't know about others.
In lighter vein, if you come clean shaven and have a haircut, your internal examiner also may not recognize you.
See, one point I want to highlight to all the students that when you are saying anything in the exam, it is like a game of chess. Every move has to be supported. In your clinical examination, you say BP 120/70 and you make a diagnosis of severe aortic incompetence, you fail. Whatever you utter in your physical examination, whatever you say in your findings, each thing has to be supported. So don't make a mistake. If you made a diagnosis of AR, don't say pressures 170, 120/70. The cardiomegaly and blue baby, no, that will not be given to you. So these things are standard things where you have got to constantly do a retrospective examination before you present your case.
This example for here, right aortic arch. Now, what were the consequences of he said right aortic arch? Don't make fictitious things. There was no right aortic arch. It was left aortic arch. It was a right aortic arch. Immediately you must think what? That the tetralogy is severe. By what do you mean by severe? I expect annular hypoplasia or RVOT obstruction to be more. So you have to build your case. Don't try to fit in things which are not there.
Both these two boys got lost in that, calling it as a left eye. Aparajita luckily did not go to that facility because I'm sure if she were to be that, she would have done the same.
She would have said the same thing. This is where knowing the diagnosis can make you go into trouble.
Another trick about answering in your examination, don't answer more than what the question requires.
Yes.
Don't volunteer information because you can get
No problems.
got into a chakraview because of your volunteering that Dr. Anil Tendolkar
And
said.
answer what is
Answer
asked.
only what is asked, not what is not asked.
Thank you. Thank you so much. Sir, I think the examiners are very kind, sir. Thank you.
Yeah, the next coming up for the second case are Dr. Roshan, Dr. Karan, and Dr. Shravya. Shravya is from Jayadeva, and Dr. Roshan and Karan both are from Narayana Hospital. So the examiner for this session are Dr. Anil Tendolkar sir, Dr. Prasanna Simha sir, and Dr. Vinayak Shukla sir.
Now,
Kindly
what
clear
we
the
want to
session.
do here is, we want you to understand how an examiner thinks. So for this, what I want is, I want the board. Please get the board. How do the examiners think? See, the examiner, when you are giving the case, please get the board by that time. Whiteboard. He may not be even knowing what the case is. But what is he trying to do? You are telling something and he is reconstructing your case and seeing whether it matches the examiner's clinical findings. And the thing, see, everyone knows this is a tetralogy or whatever the case is. But I build up a mental picture of what you are doing. So we are going to build, one of the other candidates will build the mental picture in, like how the examiner is going to do. Okay. The pen, please. The pen. So we have 4 chambers of the heart, and we have 4 chambers of the heart. This is what we are, when you are telling, we are going to keep adding, subtracting to whatever you are telling. Okay, better pen, please. Not that. So you have 4 chambers. Cardiac surgery is very simple. You have got some these veins, I mean, you've got some systemic veins, you've got some pulmonary veins, you've got arteries coming out. Now your job is to connect. You have to tell, are they connected properly? Is there any communication? Is there any obstruction? That's all that is there in this. You are going to tell the same thing now. Inward, what we call, sir used to tell, contract bridge. You know the game contract bridge? I put 4 of heart, north, south, east, west. I put 4 of hearts down. Means, and in I am north, I put 4 of hearts down, and then south picks it up, means he is trying to build some heart swing. Or I put 3 of hearts down, I am trying to put something with a 3 in it. It could be 1, 2, 3, 4, or 3, 2, 3, 4, 5. So I am trying to tell the other guy. Similarly, you are trying to tell me RA is big, this is pulmonary artery is big, RV is big, something. So that's what you're going to tell. So one student come here, who is not, while you are presenting, you are going to build the picture. Come. So this, you have to be here and you have got to tell us. Okay, go ahead.
Good morning, sirs and my colleagues. I'm Dr. Shravya from Jayadeva. I'm going to present Acyanotic heart
Incidentally, in
disease.
the DNB exam, you're not supposed to tell where you are from. Be aware. Next.
I personally feel students should not say, I am going to present one acyanotic.
Yeah.
Or I am going to present one cyanotic.
You don't know the diagnosis.
The previous girl said, I am presenting a cyanotic patient. You should straight away start presenting.
My patient.
My patient?
That means your supervisor has
told you.
Student examiners, no supervisor has told you. Now you have to pretend supervisor has not told you, and you have arrived at your diagnosis through your vast intelligence. Understand? So total, it's a real
game.
It's a real game like this. Understand? So you have to behave as if you know nothing, and you have arrived at a diagnosis sheerly from your knowledge. Vast. Okay? Chalo, start.
My patient is a 7-year-old female hailing from Karnataka.
So my technique is stopping you on every word. Okay? So whether cyanotic or acyanotic, 7-year-old, which diseases are totally unlikely? See, you every second you take, your chance go down. Quickly tell.
Ischemic heart disease.
Quickly tell 3 diseases which are just unlikely.
Ischemic.
7-year-old, ischemic heart disease came to your mind. Okay. Then rheumatic valvular heart disease, carrying the same thinking. Congenital heart disease, which are unlikely. 7-year-old.
TAPVC, who presented
TGA.
TGA.
Truncus, hypoplastic
Who
left.
presented birth.
As I told you, don't have to tell 20 causes. Quick 3, 4 causes.
Tricuspid atresia, pulmonary atresia.
Tricuspid atresia with type A, pulmonary atresia also. Okay. Severe forms. Okay. Number 2, second group is which are likely. He's standing behind you and muttering in your ear has been noticed. What is he trying to do? He's trying to block your temporoparietal lobe. He's your friend or enemy? Enemy. Because he's trying to block your temporoparietal. If he's going to stand in the same position in exams, it is okay. Is he going to be there like this? Like Bhagwan Sri Krishna standing behind Draupadi and providing all the clothes? No. So let us be understanding. He's not helping you. Understand, my dear gentlemen? What's your name? So is this an exam of coming correct? तो आपकी जो करनी है ना वो खराब है.
Ethical problem. Ethical problem.
Okay, coming back. 7-year patient, 7-year. What diseases come to your mind?
Moderate, simple acyanotic heart diseases like ASD.
Like ASD.
Moderate sized VSD.
Very good. I like that word. A small or moderate size VSD. PDA.
PDA mostly it will be diagnosed early.
Even could be a small moderate size.
Small.
AP window.
Not big.
See why you're stopping? AP window.
No,
7-year-old.
No.
Chance.
No.
Low chance.
Low chance.
Cyanotics.
They will be presenting early.
Cyanotic 7-year-old just now.
They can.
14-year-old.
Not the first.
So well balanced. What is cyanotic presenting late?
Yes.
So well balanced RVOT obstruction and compensation. So RVOT obstruction is moderate, well compensated, will present late. So simple.
Yes, sir.
Okay, understood?
Yes, sir.
So this is how the thinking should go on.
Yes, sir.
Go ahead.
So immediately, no ductal dependent circulation, no mixing, major mixing lesion like that. Parallel circuits out.
Out. Go ahead.
Sir, the informant being mother is reliable. And I have examined the baby in a sitting position. Sorry.
You're taking history,
Sorry,
I thought.
sir. Sorry, sir. The patient came to the hospital with chief complaints of LRTA for the past 1 week and history of palpitations from the age of 1 year.
Any adjective you use for LRTI?
Is it the first time that the child has come?
No, sir.
Then
there is one adjective to be used for LRTI. Sorry?
We shouldn't be recurrently asking you the question.
Recurrent LRTI.
Like recurrent LRTI.
This is the internal telling.
What is the definition of recurrent?
4 to 5 episodes of...
So change of season. But in India, there is only one season. Summer. Less summer, summer, more summer. So classically, change of season. Okay? So I agree with you. 3 to 4 episodes of lower respiratory tract
infection requiring hospitalization.
Other causes of recurrent LRTI?
Otitis media.
Otitis media.
Sorry, sir. Sorry. Cardiac causes.
Not necessarily cardiac. No. All other causes.
Recurrent LRTI.
If a pediatrician gets a baby of LRTI again and again, what are the
other things?
Cardiac, respiratory, like any malnutrition.
As a cardiothoracic surgeon, if I get recurrent respiratory tract infection and there is no cardiac cause, as a cardiothoracic surgeon, a 6 or a 7-year-old child comes with recurrent respiratory tract infection, what is the first thing that you must rule out which can change the life of the baby? As a cardiothoracic,
Do that.
answer is an aspiration. Foreign body.
Foreign body. And next is allergic bronchitis.
That is a
These
medical
are the
cause.
causes of recurrent LRTI. Okay, go ahead. Recurrent LRTI.
Recurrent LRTI from the age of 6 months, sir. History of presenting illness. The child has been having recurrent LRTI from the age of 6 months. Till the age of 6 months, baby has been apparently normal. From the age of 6 months, she had been having 6 episodes of LRTI for the period of 6 months, for which she required 2 episodes of hospitalization, which have been relieved with oral medications, and she has been given cardiac. She has been examined and diagnosed as congenital heart disease at the age of 1 year, and there is a history of hurried breathing and chest retractions at that point. And mother has also noticed palpitations in the child from the age of 1 year.
Mother doesn't notice palpitation. She
Increased
notices-
precordial activity.
Thank you. Now, the same question will be asked. What are the things which give rise to increase precordial activity?
Just
so sternotomy we had discussed. Same thing.
Now, just one point. Build the heart, as he is telling. You've got to tell me, build the heart. Recurrent respiratory tract infection. Build the heart. What information have you got? What chamber can you tell is more dilated or big? Can be, no, is. PA is probably big. Put plus. Then any other chamber.
You are writing this for you to read or for the crowd
to read. And
so the font should be not 9, 8, 6, aisa, but 36.
Right there, plus, big plus.
Can you rub out that artwork? Great.
Then camera is behind you here. So don't stand. The camera is here.
His mind is transparent, but his body is not.
Then?
Okay. So basically, LRTI in a congenital heart disease is because of increased pulmonary blood flow. So PA is enlarged. And for PA to get enlarged, what else also will be enlarged?
RV.
RV. So write down.
Plus. And then
write down RV. Very good boy. Excellent. Understood? So this is how we are trying to develop. Plus mother has told increase precordial activity. So RV enlargement is likely or unlikely?
Likely.
Likely. Understood? So just from your story, we are writing down. Now you told the all problem began 6 months late. Suppose this is very accurate. Mother is extremely intelligent, medically oriented mother. What out of the 3 shunts it could be? In short, which shunt develops at the age of 6 months and later?
Yes.
And which shunt develops at birth?
If it's a moderate size VSD, it can develop at the age of 6 months and later.
Newborn baby with a large VSD has this thing? Newborn baby with a large VSD, will it be symptomatic at birth? How many babies have you seen with newborn coming for VSD closure?
Will not be symptomatic.
Might be in failure.
So symptomatic, no?
Yes, sir.
Failure means some symptoms.
Yes, sir.
Refusal of feeds.
Does a newborn really a newborn baby with a large VSD really become symptomatic? Or which of the 3 lesions you know? Which of the 3 shunts a newborn baby will be symptomatic? In fact, we intervene either by a drug or we do PDA.
So PDA, little later, VSD, little later, ASD. Remember, this is the time scale of various congenital heart disease.
Why ASD is the last?
Because the pressure, the PA is compliant in.
The PA is
RV compliance. RV compliance.
RV compliance will develop for development of shunt. RV compliance has to go up, increase. That takes approximately 2 years.
So what is the RV pressure? That means RV compliance has to come.
RV
Anybody in
pressure.
the audience?
What RV pressure is going to?
We'll answer our own questions. Or you can be
Newborn baby
current
circulation.
Sir,
You
What is
know?
the RV pressure and LV pressure when the child is born? What is the fetal circulation, in other words? That's all.
Is the pressure, RV pressure high in a newborn or not? Yes, no.
RV is injecting into PA, into PDA, into
PA
descending
pressures are high,
thoracic.
so RV pressure is high in newborn.
So RV pressure has to touch baseline for the ASD shunt to start.
Yes, sir.
EDP.
Okay, understood?
Yes, sir.
Go ahead.
Please
Then in
don't yawn.
admission, preferably you must mention admitted for what? Did the doctor tell the diagnosis? Was it pneumonia or infective endocarditis or just simple fever or breathlessness, if possible? Or you can declare, I tried to find out, but mother could not answer. Okay?
And
So
they said
at
it
this
is
stage, just 3 words you have spoken. What is our diagnosis?
left to right shunt
At the
with the
at
increase
what level?
ventricular level.
Okay, understood?
Yes, sir.
Just from your history.
Yes, sir.
We don't know the case at all. Go ahead.
And history of failure to thrive has been noted, sir, from the age of 6 months, and suppressed cycles have been present. And baby had to take a long
So
time
whenever
to
you
complete the
say
feed.
history of failure to thrive, you should be able to tell quickly the weight of the patient according to age. Some formula which I don't know, you may bluff anything, but you should able to have kya? Age plus 7 divided by some 3, something of that sort.
3 or whatever,
Quickly
but
able
have
to
some
say.
formula. Now, based upon
Remember,
failure to thrive, the child
what?
is having
Twice
increased
the
birth
birth
of
weight, twice the birth weight at 6 months, 3 months. Three times the birth weight at 1 year, 4 times the birth weight, 2 years, 60 pounds, 60 kilo, so 6 years.
and
Child
weight into
is-
3 about 2 years. Weight
Sorry,
into 3
60
about
pounds. 60 pounds, not 60 kilo. Sorry.
weight into 3 about 2 years of age is a simple formula. You can, now I want to know. You said the child is having failure to thrive and difficulty in feeding and suck recycle
And forehead sweating, sir.
and forehead sweating all top of it. What now? You tell me.
Forehead sweating suggests what?
CCF, congestive
Increased
cardiac failure.
sympathetic activity,
Activity.
suggesting
LV overload.
congestive cardiac
Cardiac
failure.
failure.
So now which chambers are you going to put up there? You said that the child is unable to feed. So it means to say that it is the equivalent of
Exertional dyspnea.
Exertional dyspnea. Dyspnea means which chamber is enlarged? Cardiac chamber is enlarged.
LA.
LA. Put plus. Rules out what?
ASD.
You now don't think of ASD. Next. Forehead sweating means what?
LV is enlarged. LV volume overload.
You are now thinking. See, the fourth line, we have already thought of this much.
Why you thought LA enlargement?
Because the child is, because otherwise ASD will get fatigue, but not.
What complaint made you think that is LA?
She said inability to feed.
Exertional
cycle.
dyspnea.
So I said that's the equivalent of dyspnea.
Okay.
LA hypertension.
So now already can you see how we are building up the picture?
But
Based on what you tell.
But I don't understand failure to thrive. What is this? Why?
Sir, baby has not been able to take feeds, and also work of breathing was more. So, whatever the energy it is being consumed, I mean, food has been being consumed, it is being spent on the breathing or
Work of breathing.
Work of breathing has
And
increased.
all the proteins
Also-
are directed towards fighting infection
Yes.
rather than building up body.
Increased work of breathing means now what is the thing that you're thinking now?
How much cardiac output of yours goes for work of breathing?
You are telling me acyanotic, but increased work
Hy-
of breathing means what?
Hyperdynamic circle.
Means more blood
In the lungs.
the lung.
Yes, sir.
More
Lung
blood
complex
in the lung.
increase.
So which congenital acyanotic diseases are you ruling out? She's giving me the looks like Jagger. What congenital diseases have you ruled out? Acyanotic congenital heart disease have you ruled out by the fact that there is more blood in the lung? Okay? Cardiac surgery, acyanotic does not mean only shunts. There are other diseases.
Coactation.
Coactation.
One, okay, but pulmonary stenosis, aortic stenosis, because they're dyspnea you're also having. So aortic late, the primary presentation of the is related. So you know, are ruling out PS and AS, not MS.
How much of your cardiac output is going for work of breathing?
20%.
Normal 20% output for breathing in you. Just now.
Anybody?
कितना होता है?
25 to 30%.
Deha ke, in Kannada there is a song, Deha ke usre sada bara illa, she says. It is normally we don't think about breathing. I give that description in the song.
20% of the cardiac.
25%.
Yes, sir, 25%. Or documented. Yes, yes.
Please that bell me.
Half time.
History over. Anything else?
Anything contributory. Can you summarize? This is very common. Summarize your history in 5 lines.
Sir,
Examiner used wrongly a word called tell positive finding. According to me, the word should be relevant finding. Even
Summarize.
something absent may be relevant. Like absence of cyanosis is relevant. It's a negative finding. Remember.
Summarize your history in 5 lines.
so my patient is a 7-year-old baby, XYZ. She has complaints of left heart failure since childhood.
From the age of
Left heart failure?
CCF.
LRTI you have said.
LRTI since the age of 6 months, the frequency of which has come down post 1 year and
it has come down more than 1 year. That's extremely
since the age
important.
of 1 year.
What is
This
the
did not tell so far, by the way.
Huh.
What are the causes of LRTI episodes coming down?
It might be spontaneous closure of the shunt, or it can be
But
Eisenmengerization.
7 years spontaneous closure. Your age is 7 years, remember.
Short of closure, something else can happen.
Decrease in size.
Decrease in size was closure only.
Anything else can happen.
What will happen in 7 years? Why the patient is becoming better? There, he is to give the answer.
What can happen? Can develop RVOT obstruction.
That typically is at the age
Gasalization.
Okay. Then what else can happen? Pulmonary hypertension, by which the flow will go on decreasing. So many times relatives feel child is improving. Better. Okay.
Okay, summarize. And then number 1, first line, second line.
And history of palpitations. History of
baby can't give history of palpitations.
history suggestive of CCF has been present, sir, with failure to thrive, SRS, and forehead sweating.
What is the weight of the weight of the baby?
It is currently 14 kg, sir.
7 year?
7 year, 14
14 expected weight? 21 kgs.
Okay.
It's around less than 80% of the expected. So there is failure to thrive and
Our
CCF.
currently diagnosis around hovers around a VSD.
Yes,
I will not commit to moderate size. Okay.
In fact, why sir said I will not commit to moderate size?
Sir, according to the picture, seems like a large VSD because
there's nothing to suggest that this is a moderate VSD.
Yeah, his child was symptomatic at 6 months away.
Precordial activity, I will think of large VSD.
Precordial activity, and the symptoms have started to come down at the age of 7. Is suggestive that this child is now having progressive pulmonary Hypertension. See, we have not.
Same question with Dr. Iyer asked. You will be asked what are the ways the VSDs will close. Okay. So 7-year-old to other causes. So likely in this age, apart from tricuspid valve,
RCC or
aortic
NCC prolapse?
leaflet. So I am going to ask you which leaflet?
RCC or NCC prolapse?
NCC, RCC. Okay. Good.
Okay. Next.
Chalo. Next, your or E. Who is next?
Examination means, sir.
Currently, who is going to speak?
Examination I'm going to present, sir. Sir, history, can I?
History is done.
It's done now.
This is where you want to be. Mattak Tarvaga, when we are telling we don't want to be.
She's from Narayan Rudal?
No, she's from my college. Do you want to invite trouble? No, then go forward.
The
This is
baby
what
has
it
been
was.
examined.
Huh?
The baby has been examined in supine sitting position under broad daylight with the mother on the side and with complete exposure of the precordial cavity, precordium. And her vitals have been stable, pulse rate being 78 beats per minute, regular and normal in volume. And quality of the vessel is normal, no radial or no radiofemoral
78
delay.
beats per minute. Heart rate, baby with 50 heart rate, 30 heart rate, what would you think of? Shunt, 30 heart rate.
Could be OP,
What is OP?
AVCD.
AVCD.
Sorry, atrioventricular cushion defects with
No short forms, sir. By
So,
rule.
AV canal defect can be thought of primum ASD. Does it fit possibility? Yes, no? Yes,
It can
no.
be, sir.
No, can
with
be.
osteoprimum and VSD
Or
also.
corrected transposition VSD.
CTGI VSD.
Yes.
Known to develop heart blocks.
Yes.
Okay, 2. Then
78, are you surprised or not surprised?
Sir, baby has fever actually.
All the
so
more.
it is supposed to be higher. So
Otherwise, the heart rate in the baby is higher. Baby is in failure. So I'm expecting the heart rate to be
high.
higher.
This
Around
is
90,
worrisome.
100.
Yes.
This is
She's saying
worrisome.
78.
So all the more.
But in your history, is the child on any medication?
Yes, sir. She has been on cardiac medications.
Okay.
Inderal.
Okay, let's see what.
That you should have told in your history, which you did not.
Okay.
You said, what else you told about pulse?
Anything about the pulse?
So normal in volume.
Yeah.
The
High
character of
volume
muscle.
pulse.
Normally in volume. So what associated thing just now we were
We just
discussing
discussed.
is less likely?
Hypertime.
No. High,
EDA is less likely.
high volume pulse rules out. See, the
AR.
child is
AR.
becoming
AR.
less
Yes,
symptomatic. Less symptomatic and high volume pulse means
No,
Yeah.
it's not due to the closure by prolapse of the aortic leaflet.
put there. Aortic valve normal.
Okay. Then you said no radiofemoral delay. So what is absent?
No coarctation of aorta.
Normal.
Is it common to have VSD and coact of aorta?
Yes, sir.
Yes.
What will be the
And it
presentation?
won't be diagnosed on echo. Please remember, it won't be diagnosed on X-ray. It won't be diagnosed on ECG. It will be diagnosed only clinically.
Clinically.
See, I'll ask you now. Why do you think this child has a coarctation?
No.
Not likely, sir.
Why?
Sir,
A child with a VSD coact will present
earlier.
and decompensate early and will not keep doing well.
Yes, sir.
Okay, next.
And saturation is 84% on all four. nodes.
84. Okay. 84% saturation is present. What is the thing in your history that you said
No history of cyanosis given by the mother, sir.
84% saturation now? You said something and I will give credence to that. And I hope if that child has got 84% saturation, please shift it to the ICU.
And clinically, no cyanosis.
No,
Did
sir.
you take a pulse oximetry?
Yes, sir.
If it is 84% saturation and reduced this thing, what could be the cause? There are two possibilities. You said something which I would say shift to the ICU. What was that? The child is having active,
Respiratory infection.
that child is having a severe pneumonia. If the child had not gotten, if the child is there, please send it to the ICU. I'm telling it, one of you people send it to the ICU. One of you go and send it to the ICU.
Sachi, we continue study करता है.
And then What is the other thing? If it is 84% with the lowering of respiratory tract infection?
Eisenmengerization.
And this is? The same, can you message me? Yeah.
Just now we spoke something that complaints have decreased.
And the child is having 84% saturation.
Patient is developing RVOT obstruction.
Gasalization.
What RVOT obstruction as worsening? That's why you asked you one question. Is the child sick now with respiratory tract infection? Active respiratory tract infection with 84% saturation means the child better be actively managed.
Normal saturation is 90%. On walk test, it drops to 85.
Okay, only on walk test it is dropping. Okay. Yeah. That means you must have made the child right and then taken the
90% and 84 it suggests an acquired RVO.
That's what I'm trying to say. You need to be very clear about it. That's why I asked.
You can't say that it is
Eisenmenger. I'll ask you one simple question. Yeah, which is the child who at 7 years can Eisenmenger? Since you said it, which child will Eisenmenger at anything, if anything, of all the shunts which you were to take, which is the child shunt which would Eisenmenger? Very unlikely, but which is the one which would Eisenmenger, if anything?
Multiple shunts.
A complete AV canal.
AV canal.
Only possibility, even that, not so early, at 7 years.
Oh.
Okay, continue. That's why we don't want to entertain that. Yeah. Next.
And blood pressure is 110 by 70 millimeter of mercury in all 4 limbs, sir. And there is no pallor icterus.
In a pediatric case, you are at a risk of being asked what BP cuff did you use. Just be aware. Okay. Where did you wrap it and how did you measure it? We are skipping that.
No icterus, no cyanosis, sir. Clubbing is present.
You gave me the number 84% with cyanosis and you are telling me no cyanosis.
Sir,
So,
actually.
Morning question, hemoglobin must be 9 grams.
Is he anemic?
9 gram, 8
No,
grams,
sir.
7 grams.
Not anemic. One side you are telling me that the child is not anemic, and one side you are saying that the pulse oximetry, you've done a pulse oximetry. Today in the exam, we give the pulse oximeter. Yes. So you cannot say now that 84% and say, yes, sorry. Somewhere along the line, you have to use your Akal. Understood? You can't say, I did a pulse oximetry, I got 84% with a good. If you got 84% with a bad reading, that's a different story. But if you have got a good reading,
You are seeing a tracing or without tracing?
With the tracing, sir.
You are seeing a tracing.
In all 4 limbs, it was.
But tracing is seen,
yes,
then only you are recording.
Yes, sir.
it's not an error of.
You put on your finger and you checked 100%.
99.
Then that the machine is showing that thing, it is foolishness to say that the child is not cyanotic.
Sir, actually, the fingertips were blue, but mother was saying it has been present since childhood only.
Now, see, you never said
You are
this.
now having. See, this is where you should not keep arguing with the examiner. I would advise you to step back and say, yes, sir. Because you are telling something, 84% saturation on the pulse oximeter means cyanosis. You can't keep harping now that there is no cyanosis. Or you be wise and tell that the saturation is 95%. But whatever you do,
There are 2 things. One is observation. Another thing is inference. Observation is cyanosis. Inference, you may say anything. Okay? A male and female together. Observation. Inference.
How are they related?
Depends upon how, could be mother and child also. Grandmother and granddaughter.
Why did you think of husband and wife?
Or even boyfriend, girlfriend.
Girlfriend.
So observation remains observation. Cyanosis is seen. Okay?
Yes, sir. But
so now you're presenting with cyanosis.
Yes, sir.
And you started telling us, I'm going to present one
Acyanotic heart disease.
Kya sixer.
Now you understand how the internal is your enemy?
And then they say examiner was very bad.
Any examiner is bad.
Huh?
See, now you wanted to present a cyanotic, you took a cyanotic case and you are trying to push it into acyanotic, which is self-goal.
Now see,
Without surgery, you want to make the baby.
now see, you are
acyanotic.
caught with a baby with cyanosis having increased respiratory tract infections.
Which decrease.
So now you are in really a chakravyuh. So now you have to come to conditions where cyanosis with increased pulmonary blood flow is there. I think you are taking us to that side.
Now see,
Any common well-known condition?
Yes.
Cyanosis
TGA
with
physiology.
increased pulmonary blood flow.
TGA physiology.
Commonest.
TGA.
TAPVC, 7-year-old.
7-year-old, we would have thought about TAPVC now.
Supracardiac, even
Not
to be precise. Intracardiac, TAPVC.
So
Which will have all these
pulmonary
features.
blood
all these features.
Increased precordial activity, cyanosis, forehead sweating,
Everything is fitting.
late complaints that 6 months may not be 6 months, may be 7-year, 8-year.
Non-obstructed TAPVC.
Okay.
I will say this is non-obstructed TAPVC. Now you understood. Teri gali mein main chali. Next.
Next.
Chali was.
Examination.
Clubbing.
We are keen to hear current. After the confusion.
Do you people agree with her findings? Yes, no. Yes, no. Huh? Yes or no? You agree with her findings?
Karan, where we have met before? Why I feel we have met before? IACTS.
Yeah. Do you people agree with her statement? Yes or no?
Yes, sir. No,
Yes.
sir.
Now you go there, let her come here. Come. Tension mein gaya.
She will have sinus.
Okay. Syncope.
So examination of the cardiovascular system.
We know you're tall.
Examination of cardiovascular system. Chest is bilaterally symmetrical, normal in shape. Increased precordial activity noted.
Now, normal in shape. In a patient whom we were thinking now with 84% cyanosis who had respiratory tract infection at 6 months of age, what does it, and 84% saturation, what would be you are thinking in your mind? You no Harrison sulcus, no this thing, nothing. Now.
Any pectus?
There is nothing. You said precordium is normal.
Yes.
In a child with a VSD, symptomatic from 6 months with respiratory tract infections, which came down with this thing. If you were thinking it is only a VSD, you would have expected the Harrison sulcus. You would have expected all that. That Harrison sulcus is not there. So now what would you think of? What would you think of? And actually, Dr. Bhat said only one diagnosis I should think of. Yeah, the acquired RVOTO. So put there acquired RVOTO. I don't know the diagnosis. None of us know the diagnosis. But acquired RVOTO again. See, keeping on telling that everything is going towards acquired. The patient is not lying. You are not seeing. None of us have seen this case. But I don't know what the final diagnosis is going to be. But if you maintain a logic, we will appreciate it. The echo may say everything. If a single investigation could have given, if clinical examination could have given all the information, we would not require X-ray, ECG, echo. I will give you a personal examination. Example, in DNB, only 2 of us placed. Me and Rohit Sahani were the only ones who passed out of 90 candidates. Me and Chitra, and I was the one who gave the wrong diagnosis clinically, but I passed. Why? Because I presented it as a TOF failure. It was actually tricuspid atresia. But then the way I argued, and they came and examined, I showed them, sir, this looks like A and a V wave. This looks like this, looks like this, look like. All those who presented it as tricuspid atresia actually failed. And I was the one who passed because I could defend every line that I said. Then I corrected myself with the X-ray, the ECG, the echo. Same way here.
Another possibility is that patient doesn't have RV pulmonary hypertension at all.
At all. But in 84%
Just
to think of.
Examination of precordium, no prominence, I will think of no pH.
No pH.
Okay.
Just one question. What is this Harrison sulcus? I don't understand.
The diaphragm full.
Many students tell one word and they expect examiner to
complete it.
fill the blanks. So you have to tell the complete sentence.
Diaphragm is not an accessory muscle of respiration.
So when the work of breathing is increased, the diaphragm is doing too much of pulling, so excess of pulling. So it causes a sulcus just below the subcostal region. At the diaphragmatic insertion.
At the attachment of it causes retraction, constant retraction of the insertion of the diaphragm on the rib cage causes a indrawing, which is called permanent indrawing and deformation, which is called as Harrison's sulcus.
Okay, so precordium normal.
Yes. Increased precordial activity is there, not. And palpation, there is
no increased precordial activity.
There is increased.
There is.
Increased.
Tell me, increased precordial activity now. What are the possibilities now? 84%. And I will tell you a common sense thing. If it was 84% saturation, would the child be coming to the cardiac surgeon? Yes, no. With increased with pH and 84% saturation, is the child going to be operable with conventional cardiac surgery? Yes or no?
No, sir.
No. So use your brain here. Understood? If I'm your enemy as an examiner, if I keep this case, what will be the operation that will be done for this child? If it was inoperable, heart lung transplant or a lung transplant with cardiac correction, whatever may be the thing. So understand, today in 2025, that's a possibility, but we are kind, we don't try to keep such cases. Next.
Yes. Palpation reveals parasternal heave. It's the only positive finding.
Parasternal heave again goes in favor of what?
Right ventricular hypertrophy.
Yes. And you grade.
So, Ames grading 1, 2, and 3.
Ames grading.
Don't say 1, 2, and 3. Just say
parasternal heave. Yes.
Ames grading.
Yes, sir.
Which one? All India Institute grading.
Yes, sir.
Sorry, wrong number. Dr. Sampath Kumar used to ask it, but it is not Ames grading.
1, 2, and 3.
His
sir.
aim is wrong.
Palpable.
First of all, don't say this 1, 2, and 3.
Yes, sir.
In the evening, I will tell you one famous story of number. Okay, just remind me. End of the session. Otherwise, Hiremath will kill me.
So, palpable, sir. Palpable.
All Prasanna sir will give us 1,000 rupees. So 1,000 on.
So grade 1 palpable, grade 2 palpable but not obliterable, grade 3 palpable and obliterable.
So this is how much?
This is grade 2, sir.
Grade 2.
Yes, sir.
So pH is moderate.
Yes, sir.
Very good.
Auscultation.
The palpation, all of you are forgetting the first is sound, next is thrill, and third is activity.
Yes, sir.
So P2 palpable,
P2
not
palpable. P2 palpable.
So who is going to?
Yes, P2 palpable.
So P2 is palpable. Number 2, any thrill felt, not felt.
No,
Patient is a
wait.
VSD man.
Yes, sir.
So your thrill is going to give us a lot of information about left to right shunt.
Yes, sir. No.
Whole discussion is going to be what? Operable, not operable.
There's thrill, no thrill.
There's no thrill.
Okay.
No, so
No
don't try to thrill us. No thrill. So P2 palpable, no thrill,
Yes.
and there is left parasternal activity.
Activity.
Okay.
Yes, sir. So apical impulse noted and felt in the left medial to mid clavicular line. And
No
the fifth
cardiomegaly, that means.
Medial to mid clavicular line. Now
Yes.
again, I'm going to ask you. You are telling me that there is a what is called PA is palpable. The shock is present in the second space.
Yes, sir.
You're telling me that there is RVH, and then what was the other thing you just said now?
There is
Heart is
Inside
mid clavicular line, within the mid clavicular line. You said
Sir,
that.
no, we have examined that it is outside the midclavicular line. I just rephrased it. Yes, it is outside the midclavicular line. So
There is cardiomegaly there.
There is cardiomegaly. We are sure that there is cardiomegaly, sir.
Because
Yes, sir.
what is if you had said that the heart is within, what would be your diagnosis? If the heart is outside, what is your diagnosis?
So two corroborative evidences that it is cardiomegaly, parasternal heave and the sympachial.
This is where I ask you a question, you give me the answer. I ask the question, if the heart is small, what is your diagnosis in this situation? Heart is big, what is the diagnosis? Yes.
of development of PS and decreased shunt will result in cardiomegaly or will not result in cardiomegaly. It is it's like a tetralogy fellow. So it will have cardiomegaly or no cardiomegaly?
No cardiomegaly.
No cardiomegaly.
Yes.
Cardiomegaly suggests volume
Overload.
overload.
Yes, sir.
Okay. In palpation, you have missed the type of apex.
Yes.
Because you are not following an order of presentation. Apex starts with apex. Apex is outside mid-clavicular line. In fifth space, it is diffuse, related to one space, two space. It is hyperdynamic. All that you have to tell me.
Yes. The apex here was diffuse, sir.
Have you written down the history?
Not entirely, sir.
Why shortage of paper? Trying to save paper, forgotten to write, didn't have pen, had pen, but no ink, had everything, but lost. Paper used for some other purpose, just before exams.
If you are telling it is diffuse and characterless, what are you trying to say? See, what are you trying to tell me?
That there is
So
left ventricular head.
And you are telling me what type of the whole story now hinges on the apex.
So कुछ भी बोल रहे हैं यार.
What is it?
Diffuse apex.
Huh?
Diffuse apex detachment.
Have you really examined all three of you? I'm asking a very serious question.
Please let us
So
stop.
where is the patient?
According to me, let us stop this discussion. They have not taken history properly. They have not written the history. According to me, it is mandatory to write down the history. Papers are given to you, unlimited, to write down the history. We have passed the student because he had written down the history correctly, but while speaking, the student fumbled. We have still passed him because he had written down the history correctly. No shortcut for not writing down history. I even prefer students writing down drawings and imagining what will be the ECG, what will be the echo, what will be the X-ray, etc. Plan of action. What does this mean? All is appreciated. Totally unpardonable. Now, can we come to auscultation?
Yes, sir.
Have you written down that also?
That is there.
Or online writing?
No, it is there.
As you are talking, you are writing. Nowadays, available, no? As you talk, it comes, appears.
Tell me.
Talk to speech.
Sir.
Speech to text.
On auscultation, we have found that there is ejection systolic murmur in the pulmonary.
Again, mistake. First heart sound.
First heart sound. Second heart
Entire congenital heart disease is on second heart sound. It is single or double, normally split, abnormally split, fixed split, moving split, loud, soft, permutation, combination.
How can you go directly to a thrill when you don't know?
This murmur.
First, what is the thing about the heart sound?
Sir, S1 and S2 heard.
That you have confirmed he's
S1 is normal.
Yes, sir.
You have confirmed that he's not dead. S1, S2 heard. That's not what we want.
What will you report about S2?
Normally split or
S2, both the components are heard and they are normally split. So what diagnosis is ruled out? ASD is ruled out. P2 component is
what is the P2?
Loud. P2 component is loud.
Loud. How? As loud as what?
How do you grade the P2?
Now she will be standing behind you and prompting.
How do you grade P2?
As loud as what? Something to compare?
Compare. What is
A2.
A2. So I'm giving you the answer because this is going very badly.
Very bad, yeah.
If it is loud as loud as the aortic sound, it is definitely loud. If it is heard well in an area where at the base it is loud. Number two, if it is palpable, it is again definitely moderate, at least moderate pH. And then if it is associated with PR or a TR or no murmur, then it is severe PA. You have to tell that. So now what
everything
is
is on
P2?
P2.
You said to me that there was a palpable P2.
Yes, sir.
Okay. P2 is loud. S2 is normally
Normally split.
Both the components heard.
Yes, sir.
P2 is loud.
Yes, sir.
Loud because it is as loud as A2 or moderate pH, heard at apex, severe pH. Okay?
Yes, sir.
Next is a murmur. Now you are using a word, some word you used, registered. Rethink and answer. What have you written down? Can I see your beautiful handwriting?
This was hers.
It is hers, so it was not an individual, it was all.
You said ejection, systolic, murmur.
No.
He said ejection, systolic.
This is his.
You said ejection, systolic, murmur. Didn't you
Yes,
say?
sir. Yes.
Huh? So what does ejection, systolic, murmur mean?
There is flow.
Hemodynamically.
There is increased flow across
First
the
heart
pulmonary.
sound, then there is a phase where there is no flow, and then the flow starts. This is typically seen in which conditions? Ejection, systolic, murmur, aortic stenosis, pulmonary stenosis.
Yes.
Why? Because during isovolumic contraction, there is no flow. As against this, in VSD, what happens? Moment both the ventricles start contracting, because of the communication, blood starts flowing. So there is nothing like isovolumic contraction. So the murmur in VSD is pansystolic. And what happens with development of pH? The duration of pansystolic murmur goes on decreasing, because RV and LV pressures equalize. Understood?
Yes.
Now still you want to insist that this is ejection, systolic, murmur.
The diagnosis totally changes.
Then again, the story will change.
No.
It will become a RV-OT obstruction. And the PS VSD murmur is almost not heard.
It's a large VSD.
Or there is no VSD only.
No VSD at all.
VSD is closed. Totally. Understood?
Yes.
Then the P2 can't be loud. With PS is so severe, P2 has to decrease in its severity. So there is a lot of jumbling, and this I will give minus marks for this, very frankly. Shall we come to X-ray, ECG, please? Echo. Let us have something factual, which they are not bluffing. 10 minutes.
10 minutes.
X-ray. ECG. Bolo.
So this is an ECG calibrated at 25 centimeters.
Then they forget, yeah.
Yes, sir.
Spot diagnosis. ASD, VSD.
So there is right ventricular and left ventricular hypertrophy both.
Suggesting
Of cardiomegaly, biventricular hypertrophy.
biventricular hypertrophy.
Yes, sir.
Don't say cardiomegaly. Cardiomegaly is X-ray concept. Cardiomegaly is a clinical concept. Here it is voltage, voltage, voltage,
Yes, sir.
and voltage. So why you call it biventricular?
Sir, Sokolov's criteria, V1.
Don't take names.
Yes, sir.
Avoid.
R in V1 and S in V6 or V5 is greater than 35.
Okay.
And then
Any other criterion? Sokolov's criteria. What is Katz-Wachtel phenomenon?
Katz-Wachtel phenomenon.
R plus S.
Sir,
R equal to S.
R equal to S. R plus S more than 35.
35 in V3,
Mid precordial.
V4. What is this V3, V4? Why V3, V4 chosen? So the LV has enlarged, and the septum which is at V5 has now, because LV has enlarged, the septum now has come to V2, V3 position. So at V2, V3, you are seeing RV on this side and LV on the other side. Okay? Any other evidence of volume overload?
Yes, he is already telling me, don't.
So for your guide is this picture.
picture.
This is what Prasanna was telling you. You have told us
Bifid.
through cards, Wachtel phenomenon,
LV and
this and this.
RB.
Can you diagnose this on ECG? My dear, look here. Can you diagnose pulmonary artery enlargement on ECG? No. Why? Because it doesn't generate voltage. Can you tell aortic enlargement on ECG? No. Because it doesn't generate voltage. So out of these now, who generates voltage?
Left atrium.
Left atrium.
Yes.
Is it enlarged? That is what we are trying to ask.
Now, teaching class is going on.
No, sir, I don't see any bifid P waves. Yes, sir.
V1.
V1.
What is the seeing in V1?
Bifid P wave.
What is it called as? I tell you the RAR. What
P
is it?
matrix.
That a negative terminal deflection in the P wave more than 1 millimeter is suggestive of LA.
X-ray. Next. Let us save him. Let us try to save him.
Whiteboard push it.
This is a chest X-ray PF of our patient. Well exposed, well centralized. No. Well exposed, well centralized, and cardiothoracic ratio of 0.5. Yes, sir.
The form of shadows.
Yes, sir.
Again, chambers. 4 chambers.
Cardiothoracic ratio of around 0.5.
Chamber enlargement talk.
No, sir.
55.
RV type of apex. No, sir.
Don't keep saying no.
Yes.
This is where I get pissed off. Don't say that less than 50% now.
It's more than 50%.
More than 50%. When I give you the answer, if you please.
Anyway, next, chamber enlargements.
RV type of apex, sir. And with
below the dome of diaphragm, biventricular enlargement. Then RA enlarged, not enlarged.
we cannot say on the X-ray RA enlarged.
Suppose I force you to say under a gunpoint. Will you say or not?
I can say LA enlargement, sir, but RA enlargement.
So what is this right heart border?
Prominent right heart border.
But not due to RA. Well centralized X-ray. Now तुम अभी मुझे फेल कर ऐसा कुछ मोटो लेके आया क्या? What about pulmonary segment?
Pulmonary bay is obliterated. Full. Sir, bay is full, but
pulmonary bay.
Yes, sir.
Listen to me.
Pulmonary segment.
Pulmonary segment can be bayed or prominent.
It is full, sir. Bay is full. Yes, sir. Prominent. It's not prominent.
So, favor of VSD or against VSD?
This is in favor of VSD.
In favor of VSD?
Yes, sir.
Small VSD, large VSD?
Large VSD.
Then what else? I told you not to forget in a congenital heart.
Lung fields.
Lung fields.
Plethoric lung fields.
Hard plate. See that hard plate. You can see intervertebral spaces. See that end-on shadows
yes,
of
sir.
pulmonary arteries everywhere. So this is what? A case of VSD with an additional, perhaps ASD also. Right heart border, according to me, is prominent by any definition which you are refusing to accept. The supervisor has told you the diagnosis. Echo, cholo.
Echo. And incidentally, lung hyperflation. How many? 1, 2, 3, 4, 5, 6, 7, 8, 9.
Patient has got left vestibular also. I can see a shadow going parallel to
cervicothoracic side.
Going above the clavicle.
Is it?
Cholo, read.
So levocardia, AV concordance and VA concordance present. Pulmonary venous drainage is normal. Systemic venous drains, both right SVC and IVC drain into the RA. No RSVC or LSVC.
No RSVC.
No RSVC.
If you have no SVC.
Okay.
No left SVC. There are multiple VSD.
IVC collapsible.
IV septum. Yes. IVC is collapsible. Yeah. 50%, greater than 50%.
Not in right heart failure.
Not in RVC.
Not in right heart failure.
Not in failure. Very good. No significant chamber enlargement. They have not given the chamber dimensions. Okay, next. Normally, mitral and tricuspid valve, interventricular septum,
Large size, non-restrictive inlet VSD with subaortic extension.
My God, almost everywhere. Inlet VSD with an
Subaortic extension. Yeah.
Fantastic. Difficult to, everything is fantastic in this case.
Measuring
additional two apical VSDs.
So now, why do you think?
Plus PDA.
So now, you want to operate this child?
No, sir.
Why are you not wanting to operate?
There's a bilateral shunt already.
Bilateral shunt.
Right to left shunt is there.
Bidirectional
shunt is there.
Now, what makes you say that I will, in your clinical examination, what made you say that I will not? Right from beginning, they are talking Eisenmengerization because they knew the answer.
Eisenmenger is from birth.
From birth. I'll ask you, why did this child Eisenmengerize early? Given the echo, why did this child Eisenmengerize early? In fact, the answer is there because I gave you the answer in the beginning. In fact, the name of the VSD, what is the name of the what is the type of VSD which is written? Large size, non-restrictive inlet VSD. The other name is also called as a Eisenmenger type of VSD. So this has got a proclivity to go and become Eisenmengerized. And that is the reason why this child
is the tricuspid valve annulus will form the margin of the
VSD.
And such cases, usually tricuspid annulus and mitral annulus are at the same height.
And do you remember what did I tell you? Which is the VSD, if any, which will Eisenmengerize at 7? It was?
There is no.
Suppose this case is operable. You are tested, operable, plus 7-year-old, relatives tell, don't worry. What will you close first? PDA or VSD?
PDA first, followed by.
Take 1 second to answer. You lose your mark.
I don't close either.
No, suppose you are close.
Borderline.
Forget left to right shunt. On X-ray, you said good plethora. I believe X-ray more than this. What will you close first?
PDA first.
When? In the entire surgery, when? Extreme fundamental.
Going on.
Before going on, but after
before going on,
pump.
Very good. How do you do it? Why you want to do it before going on?
Let's do it at the end of surgery.
The flows
Returns.
I'll do it at the end of surgery.
No, sir, we still have returns during our VSD closure.
One return.
One is return.
Yes.
Flow
to the.
Hypotension. One is return. Number 2 is hypotension. 3, you won't be able to see the VSD. So much will be the return. Perfect. How do you do it?
Sir, I have done RAC, SVC IVC cannulation, followed by.
You are going to ligate.
Where will you find a PDA?
Trace the left pulmonary artery, go medially upwards. LPA, tracing the LPA.
Trace the MPA.
Not LPA.
MPA, and then.
Where is the confluence? Where is the, from median sternotomy? In median sternotomy, where is the duct? In what line do you see the duct? You mean to say, I will tell you, come here.
So PDA, I'm finishing.
Okay, finishing it off.
PDA is in line with MPA. And just behind MPA, is descending aorta, far posterior. So like OM position, you turn the patient on your side. In this case, you can go on bypass because MPA is tense, but ask the perfusionist to keep the patient warm. Okay, and you define PDA, define LPA, define RPA. I insist on putting a line into femoral artery. So by looping, by mistake, I go around descending aorta, I can immediately. So these three things have to be defined. So you pull the MPA down with some forceps or right angle mixture and trace it, it will go into main pulmonary, sorry, patent ductus arteriosus. Okay?
Please correct. He said you go on the superior part of the LP and come medially to locate the ductus.
RPA this side, LPA.
But this is the direction.
But the direction
which helps
is
you.
in line with the
Okay.
LPA.
Chalo, over. Thank you.
Yes, sir. Silver brands.
Good, sir.
Silver brands manual.
So great people think alike, silver and.
I thought you were in gold category, sir.
Sir, you have to give your evaluation.
Extremely poor because you are mentally prepared for that Eisenmenger. You are not written down the history, not writing history. According to me, doing me well.
Did you all examine the patient and come to a diagnosis, or were you told to the diagnosis?
Honestly, tell us.
Honestly, tell us.
Honest.
Sir, it was initially
Initially examined, then good. Spirit eyes are either.
Huh?
Do we get spirit
for the,
here?
after 6 months of age to 1 year, baby had.
I think. Did you clinically examine the case? When you took the history, when you had a saturation of 84%, you had no business to call it a acyanotic heart disease.
Now, what is the difference between the Eisenmenger syndrome, Eisenmenger complex, and Eisenmenger reaction? All of you, please make a note. What is Eisenmenger complex?
Exam, we don't keep such a case
Eisenmenger
practically,
syndrome
but this is how you screwed yourself up.
and Eisenmenger reaction. This should be Eisenmenger syndrome or Eisenmenger complex.
Eisenmenger described for whom?
They'll answer the question.
Okay, they may not be knowing it. The thing is that if we put this by mistake in the exam, if you get this case, what will be discussed? For your bad luck, it will be lung. If because, as a surgeon, this will be a case for lung transplant with VSD closure.
Sure. Remember, pathology remains the same. What you see is various aspects of the same pathology. Clinically will be something moving. On X-ray, shadow. On ECG, voltage. On echo, the chamber dimension. But the pathology of VSD will remain the same. So for every diagnosis, you must know the pathology. Then you will be able to answer everything. So what will be the X-ray? What will be the Chai ka time?
Tea is ready. We'll get back in 10 minutes. We're running late.
Okay, fourth floor.
No, it's outside. Just outside. 10 minutes.
Another
Be back,
trick.
okay.
Another trick for all you guys.
Examiners were fair enough.
Only surgical question is okay.
Sure.
अभी ऑनलाइन है कि नहीं? The examiner for the next session are Dr. Balram, Airan sir, Dr. Baiju, Dharan, Dr. P.S. Seetharama, Bhat sir, Dr. Brijesh, Kottayil sir, and I request Dr. Anil Tendolkar sir to chair the session. Seetharama, Bhat sir, and Anil Tendolkar sir. Sir, kindly chair the session, please.
Will start? Yes.
Formalities. When did you arrive, sir? At what time you woke up? Okay. Balram is online.
Sir is online. Good.
Okay. What's your diagnosis?
My diagnosis is the VSD with RVOT obstruction.
VSD with the RVOT obstruction. Congenital
Provisional.
Calling it tetralogy of Fallot.
Because I'm not complete.
These are full toss questions. Even if you take 3 seconds, it is gone.
It could be tetralogy of physiology, sir.
Then
but
why are
I'm
you not saying physiology?
What is the difference between the two? When you say VSD, RVOT obstruction, and when you say TOF, what is the difference between these two morphologies?
Pathologically, clinically, everything.
So, in TOF, we have a large.
No. First you said VSD who has developed RVOT obstruction. This is what you meant, isn't it?
Yes, sir.
So if it is a VSD first, what will be the picture like? Just now?
Discuss now, no?
Patients will have recurrent LRT. Recurrent LRT.
Patient will complain of first recurrent LRTI. Then what will happen? LRTI will decrease. And then what complaints will develop? Easy fatigability. This patient will be at what age? All this will happen. Somebody has joined. Balram sir has joined. Good afternoon, sir.
Good afternoon.
Brijesh sir,
How are
good
you?
afternoon. Sir, good afternoon.
How are you?
Good afternoon, sir.
Good afternoon. Good afternoon. See, let us introduce.
Candidate is saying his case is VSD with outlet obstruction, RVOT obstruction. So we have asked him, why aren't you calling it tetralogy of Fallot? Go ahead.
Dr. Tendolkar. Hello.
We started with the diagnosis. We asked him to give the diagnosis.
This is the second case of cyanotic heart disease. So avoid repetition. We have changed the track.
Dr. Tendolkar.
Surgery.
Hello.
Yeah.
Hello? Can we know the name of the candidate first?
Name of the candidate first, please.
My name is Harish, sir.
Harish. And who else is presenting?
Pratik, sir.
Pratik. Okay.
Yes.
All right. Let us start now.
Can you see the screen? Atisha Hall 2.
Yeah, I can see it.
Sir, if you click on Atisha Hall 2,
yeah,
it'll
you can see the candidates also.
I can see the candidates. I am hearing you also.
Okay, go ahead.
Yeah.
So we are asking you the difference between the two.
No, before you go into that, what do you mean by TOF physiology? Please tell me that, clarify that. Tell me what you mean by TOF physiology.
It is a large single subaortic VSD. Non-restrictive subaortic VSD.
Malaligned.
If you want to answer, please go ahead.
Large VSD with decreased pulmonary blood flow
where the blood flow is determined by the pathway of least
VSD
resistance
with what?
through the
Right
plate.
to left?
Right to left shunts.
Significance is right to left shunt, reduced pulmonary blood flow, and interventricular communication, which is non-restrictive.
And this is a physiological definition. So mal-aligned, those words are not important. More important is non-restrictive VSD. So this picture is not tetralogy, but is VSD with RVOT obstruction because
The VSD does.
Balram sir and Brijesh sir are hearing. So better talk into the mic.
Yes. The VSD does not seem to be a non-restrictive VSD in this case. And the pulmonary blood flow is also not reduced, although RVOT has developed over time.
RVOT obstruction has developed over time. And this patient complaint started.
Approximately 2.5 to 3 years ago.
And patient at current age, who is going to speak all that you speak, man? I have been accused of I only speaking. But for that, you have to speak.
You made a statement that RVOT flow is, the pulmonary artery flow is less or more in this case. Now.
Dr. Tendolkar.
We are talking only about history and things of that sort. So please, when you say top physiology, what are the points that you are considering to say it is top physiology? Start with clinical, symptoms, signs. Tell me. Okay, question passes on. Pratik.
For saying VSDPS, patient should have history starting with the recurrent LRTIs, which subsequently stopped. LRTIs are reduced over a period of 2 to 3 years, and then once the patient developed PS.
In this patient, what are the features which are supporting your diagnosis of top physiology? Please let me enumerate that.
Sir, I cannot comment on this.
Since you have not taken the history.
I have not taken the history.
Who has taken the history?
This patient has given a history of recurrent LRTI, sir. The age of the patient is a 9-year-old female, sir. So she, although she has given chief complaints of easy fatigability from the last 2.5 to 3 years, before that, she had a history of recurrent LRTI, which gradually subsided with age. And to present day, right now, she doesn't have an LRTI, but her main chief complaint is easy fatigability.
And to make it top physiology, there is another word which needs to come in. Right to left shunt.
Has she got cyanosis?
Cyanosis.
Central cyanosis.
In this, no, sir. The patient does not have cyanosis.
So then why do you call it as top physiology?
I did not. That is.
He did not say top physiology. He said VSD with RVOT I asked him why this is not top.
Yes, sir.
So this is the reason that no cyanosis.
No cyanosis.
That's why you are not calling it.
Also. Yes, sir.
You are not calling it
as top.
Okay. So to say VSD with RVOT obstruction, you heard two different murmurs or only one murmur is heard?
I heard a pansystolic murmur along the left sternal border, sir. And I could make out another systolic murmur at the pulmonary valve level.
What murmur at pulmonary valve level? Ejection systolic murmur.
It was a systolic murmur, sir.
Suppose I say it is pink tetralogy. How will you differentiate between the two clinically?
It's ejection systolic murmur.
But at the same time, a murmur along the left sternal border and a separate murmur you could hear in pulmonary area.
No, sir, I could not make out between the both of them.
So then why are you calling it RVOT obstruction? Why this is not the case of VSD with no pH?
Because of the history, sir, since her recurrent LRT has subsided and now her main complaint is easy fatigability, I presume that the RVOT obstruction might have developed over time.
Otherwise, she can get pulmonary hypertensive also, same thing, no? Why do you want to come to RVOT obstruction in your first statement itself?
VSD who is symptomatic and now becoming asymptomatic, the first thing that you would have thought of is pulmonary hypertension is the commonest cause, no?
Yes.
Dr. Brijesh wants to say something.
Brijesh.
Yeah, I just want to clarify that. See, if you
Can't
have
hear you,
Can't
Brijesh.
hear you.
Unmute.
You have to put your
Unmute.
mic on.
You have to unmute.
He is unmuted here, but the mic has to be put on. No, it's not. His problem is his mic.
The simplest thing for the first question Dr. Tendolkar asked you,
the mic,
what is the difference between
Hello?
Yeah, now you're audible.
RVOT? You could have
Krishna.
just said that
Shri
it was,
Krishna.
it was a
Brijesh from.
Am I
Kochi.
audible?
No, again.
Yeah.
We can't hear you, Brijesh, sir.
Sir, I'll just see whether.
Yeah. Heard.
So I just want to clarify the see if you have a large VST and you are saying that there is an RVOT obstruction, but you are hearing a pansystolic murmur. These two will not go together. If you are having a large VST, you are having a pansystolic murmur, but if you are in the same way you are saying that you are suspecting RVOT obstruction. So there are three possibilities as sir has told. You said that the patient was symptomatic, symptoms came down. So the possibility would be either RVOT obstruction or another thing is the VST itself becoming restrictive. That is the second possibility. And third one is development of pulmonary hypertension and isomerization. So from the history, when you have a large VST, as the VST progresses, these are the three pathway it takes. So the history as well as clinical examination would try to find out whether it's a pulmonary hypertension developing or there is an RVOT obstruction developing or the VST becoming restrictive. So that's probably the way you should look at.
Okay. Yes. A case of VSD which becomes asymptomatic and it is not pH development and it is not RUOTO development, possibility is that VSD is getting closed. How does the VSD close?
He is saying
spontaneously, how does it close?
Having fatigue, so it can't be VSD.
No, this is
Mechanisms of VSD.
Seetharama, I just want to make one point. How people get into trouble because of the first question, which was whether it is TOF or VSD growth. You should have said this has been an acquired situation now. Patient had, as per the history, because we didn't talk about the history. We went to diagnosis straight away. So you should have said that this patient had symptoms of VSD, which later on converted into this thing. It's unlike a TOF physiology, which TOF, which would have been there right from the beginning. So then the further things come about.
You told me that you said RUOT obstruction because the symptoms have subsided. What is the percentage of the patients who develop RUOT?
I don't know.
Anybody? It is only 10 to 15%. Not more than that.
Rule of 10%.
Yeah. Now, so what is the other mechanism of the symptoms coming down? I'm telling mechanism which reduces the left to right shunt. One, as Dr. Brijesh said,
development of pH.
Development of
pH.
And then
third,
the VSD becomes restrictive.
Huh?
Third, that is
how spontaneous closure. One more mechanism.
We discussed it just last case.
RCC
Prolapse and causing an RCC prolapsing into the VSD and then closing it. Why does that prolapse?
Venturi effect due to the increased shunt.
Is it common with a large VSD or a small VSD?
Smaller VSD, sir.
What is the mechanism of this prolapse occurring in a TOF, in a large VSD?
Question passes on.
Quickly. Basically,
Why,
the mechanism.
why does the prolapse, why does the acquired AR happens in a TOF?
Due to dilatation, root dilatation.
Root dilatation, is it not? Don't use the word venturi there. In tetralogy, don't use the word venturi. Till lack of support, it prolapses. Okay, right. Now,
What are your findings, relevant findings to say, apart from history, clinical findings to say this is VSD and additional RVOT obstruction? There are no findings, only findings of VSD.
Sir.
Okay, can we go to X-ray?
Just before
Yes.
that, Dr. Tendolkar.
X-ray or CG, whatever you have.
Balram is on.
Hello.
Sir,
We should ask him. Suppose I say it is pink tetralogy of fallow. So what will be the clinical findings different from the VST developing PS?
Sir, initial part we did not hear. First sentence we did not hear.
Suppose I say it is pink tetralogy.
Sir is asking, this is pink tetralogy. Defend
So
your-
how will you differentiate pink tetralogy from VST PS?
Pink tetrad versus VSTPS.
Yes.
Cyanotic spells. Tetrad.
What is it? Yeah.
Tetrad will have cyanotic spells.
Okay.
But it is a pink tetralogy, very cyanotic spell then.
Pink tetrad.
That's a basically came down to the same thing. What is the morphological difference between the VSDPS and a tetra?
Tetrad, there is
Tetra will have
enterocephalar deviation
the
of
typical
ulnar septum.
large, non-restrictive
Malaligned
VSD,
But
subaortic,
but-
and so will not produce a murmur. Okay. And
What
in a
else? What else
VSDPS,
clinically?
the VSD produces the murmur,
Yes.
and it may mask your
Pulmonary stenosis.
pulmonary stenosis murmur.
What about the heart
Okay,
sounds? Heart
Am I
sounds.
right, Dr. Balram?
Now, what about the heart sounds?
Yeah.
Heart sound.
Sound.
The difference in the
Single
heart sound
heart.
between the two.
Single heart sound will be present in the top, sir.
Right.
So,
Why? Why so?
hello?
Yeah.
Why so?
Yes, top will have single heart sound, which
Why?
is A2, which
Why?
is heard prominently.
Why?
But
Why it
the
is single heart sound?
Yes, sir.
Why it's single heart sound?
P2,
No,
normally split A2, P2 with P2 component, loud,
loud.
which over a period of time will become soft, but it will be heard.
But why P2 is single in tetralogy of fallow? Why second heart sound is single in tetralogy of fallow?
Yeah, that's what he said. He told that answer, sir.
He wants to know why it is single.
Okay.
Why is it?
Why is it single?
Pulmonary steno, the blood flow through the pulmonary arteries.
What is the position of the aorta?
Aorta is
EOF. Aorta is
anterior.
Anterior?
Yes. As anterior.
Dilated.
What else is it? Why is it truly a single sound?
And it is
Just
most
because it is
anterior,
anterior doesn't make it
close to
single.
the chest.
No, close to the chest, but it could still be heard. But why is it never heard?
Where is the main obstruction?
What is it? The blood is permanently dammed. The pulmonary valve is permanently domed because of blood which is dammed in the infundibular chamber.
There is no movement of the leaflet
movement.
of the pulmonary valve. It is always like this. It won't move.
It is permanently
For it
domed
to
because
close
it's
and
damming
twist.
of blood in the infundibular component. It never gets an opportunity to close.
Shall we go further?
Yeah, please.
I think this time they have to go to surgery.
Sir, shall we go further?
Please, sir. Please do.
Okay.
Okay, go on. Go on. Next.
Brijesh, sir,
Yes, sir.
Okay.
go ahead.
Can we
Yes,
get
sir.
the-
We can move forward.
Go
You
on.
want
Okay.
ECG or you want X-ray?
Go to the echo first. Echo finally. Echo.
Okay. Echo finally.
X-ray, X-ray.
X-ray.
X-ray. You still Balram was telling.
X-ray, please. Is it compatible with the diagnosis of tetralogy?
Can you have full screen X-ray?
Okay, we can see that.
Oh,
Okay.
Full screen
Yeah.
X-ray.
Yeah.
Yeah.
So just read.
So it's a chest X-ray PA view taken in the erect position, and it's well centered, well exposed.
It is, if you want to use the word expose, it is overexposed.
Overexposed.
Or you can use the word hard plate. See, intervertebral spaces at T12 L1 is seen.
Yes.
What is very obvious?
Cardiomegaly.
Cardiomegaly of what? 100%, 99%. You have to tell some percentage.
CT ratio of about
Just 50%. Anything else? Very obvious.
MP. The pulmonary
You are
segment
not
is
following the order. After CT ratio comes what? Either left heart border or
right
right
heart
heart
border.
border. Which border you want to follow?
The left heart border.
Left heart border. It starts with
Aortic knuckle.
aortic knuckle.
See?
The aortic knuckle is not prominent.
Where is it?
On the other side.
It's towards the right side.
So right aortic arch goes in favor of RVOT obstruction development in VSD is far more common with right aortic arch. Okay?
Yes.
Gazul's cases were dominantly with right aortic arch. So don't miss that.
Yes.
What about the pulmonary segment?
Pulmonary segment is full, sir.
Full. क्या किधर गया वो लड़का? हाँ, his bay. See the full segment. So goes in favor of what you are suspecting. Which tetrads will have full pulmonary segment?
When no. In a case of VSD RUOTO, if you see a pulmonary segment like this, where do you localize the obstruction?
It's the obstruction.
Where is the obstruction?
Is it valvar, subvalvar, supravalvar? I can't make it more clear.
Supravalvular.
How can a supravalvar obstruction be?
How can?
Have you heard about? No, there are three. You say supravalvar, subvalvar. Now what is remaining? What is post-stenotic dilatation?
Yes.
So it has to be valvar,
If at
not
all the
subvalvar.
patient has got a obstruction, it will be at the level of valve. You are seeing a post-stenotic dilatation.
Could be. Okay. Then, as I told you, don't miss the lung fields.
Lung fields.
So what do you think? Ideal, not an ideal X-ray for lung fields. It's too hard.
But even then we can see.
But even then, you can see
make out the
pulmonary vasculature. See on the right side, reaching the diaphragm.
Yes.
Well beyond the diaphragm. So this goes more in favor of VSD without RVOT obstruction. ECG. ECG please. EKG.
Yes. Yeah.
So
you just tell what is going in your favor.
Right axis deviation, sir.
Nothing is going there, solely RVH.
And we can make out right ventricular hypertrophy.
Axis beta. Axis.
Right axis deviation.
But how much right is right?
Around 130.
91 or 179? See, R in V1 is 20. Sorry, R in AVF is 20. R in S in 1 in R plus S summation in 1 is how much you think?
225.
Little less.
25.
So it is more towards 90.
90.
Rather than, okay?
So mild
Then
right axis deviation.
what kind of loop? Clockwise, counterclockwise? 2, 3, AVF are showing, 3 is showing Q, AVF showing Q, So clockwise loop. So perimembranous VSD. And what? Array? What is the V1? Which of the this is V1? One on
that
side of the V1.
V1. It is R by S in V1 is how much? 9 by 0.
So in favor of ECG is more like a tetrad. Prasanna?
Yeah.
ECG more like a tetrad or pH? VSD.
Not pH.
VSD with pH.
LA forces
What
are
about
still there.
LV?
LA
LV
forces are
development?
still there.
Don't look at me. LV is there.
LV is there. LV forces are there or not? Yes or no? V6, what is the height? Is there a R wave there is V6? Yeah. V5 is how much? Nearly 20.
Yes, sir.
Then how can you say that?
Only RVH predominant. More of
Okay. Echo.
Echo.
So ECG
Echo
is
will
not
be
adding to your diagnosis.
No, because the pulmonary artery is there, it will be absent pulmonary valve. Let's see.
Ah.
Oh, I am correct.
Go on reading.
The situs solitus levocardia with AV and VA concordance present. The pulmonary venous drainage is normal, and both RSVC and IVC drain into the RA with no LSVC. The interatrial septum is intact with dilated RA and RV chambers. The mitral valve and tricuspid valves are structurally normal with no significant stenosis or regurgitation. In the ventricular septum, there's a large in the ventricular septum, there's a large non-restrictive malaligned subaortic VSD with about 50% aortic override and bidirectional shunt. There are no additional VSDs, normally related great arteries, and a normal aortic valve with no stenosis or regurgitation. Pulmonary valve is absent with a peak gradient of 69. Severe pulmonary regurgitation to and from motion across the pulmonary valve. 9 years. 9 years.
Wrong with the Z-score of the pulmonary annulus. It cannot be 0.1, 8 mm. There's something wrong here.
What is the weight?
24.4 kgs.
It's 8 mm. It can't be.
It is written at 22.6 kg.
What I'm saying is pulmonary valve annulus of 8.4 cannot have a Z-score of minus 0.1.
Yeah.
There's something wrong there.
Body surface area of 1, it should be 20.
20.
So it is 8, it is 12 millimeter less. So 12 millimeter can't be one standard deviation. 12 millimeter is something like 3-4 standard deviations.
Even if you compare it. Because the RP and LPA are large.
So what do you want to do?
You want to operate or observe?
Operate or don't operate?
We'd like to operate the
Why you operate?
patient. What are the natural course of the disease? The patient has a TOF, or patients with the TOF should be offered for surgery.
What is the goal of surgery?
Goal of surgery is to close the VSD and improve pulmonary blood flow without any obstruction.
And
In this case,
yeah.
Pulmonary valve also to decrease the regurgitation, PR, to
very important in this case when they had respiratory tract infection. CF plus 3.3 they are writing. I don't know, by 1 point. I don't think the numbers are not right. 20 and 22. How can this 20 be plus 3.3 and this one be? There's something wrong.
Would you like to placate the pulmonary artery in absent pulmonary valve? And if so, when do you? So you have to abolish the left to right shunt.
Yes.
You have to put a competent valve in the
Pulmonary valve.
pulmonary area. If necessary, you have to plicate the pulmonary artery. Is it?
What are the indications
When
of
would
the
you
plication?
placate?
That is the goal of surgery. When do you want to placate the pulmonary artery?
What
Where
are the
does this
indications?
pulmonary artery normalize in a absent pulmonary valve?
At what
Dharan?
level?
They are all big until the periphery of the lungs.
Pulmonary, no, sir. Sorry, sir, I didn't understand.
These pulmonary arteries are big, no? In a tetra with the absent pulmonary valve, the
Yes, sir.
pulmonary arteries are hugely dilated, so much so they may present in the child and immediately after birth with the respiratory tract obstruction. Is it not?
Yes, sir.
So it is so big. Where does it become normal? Whether the dilated pulmonary artery until
Branch level, lobar level, lobular level. This is what he asking.
Sorry, sir.
Don't.
No.
Mid hilum.
Mid.
Okay.
Your blancation is to avoid compression of the bronchus. Okay?
Yes.
Now, as a chief examiner, I will take the liberty and ask you, how do you close perimembranous VSD? This is the perimembranous VSD. Describe. Both of you can start describing.
The closure of the perimembranous VSD, first exposure is more important.
You don't have to start. It's more important. Start telling. Approach.
RA approach.
RA approach. Incision.
Incision, open the RA parallel to the AV groove.
Longitudinal incision.
Longitudinal to the AV groove.
Right AV groove.
Right AV groove.
Where do you start? Where do you end? Front, back. Where do you start?
You start
at the base of RA appendage.
At the base of RA appendage, go up to the
either in front
front
or
of the IVC.
IVC cannula.
Yes, sir.
Who is in front of you? Danger?
First.
AV groove.
AV groove.
So how many millimeters from AV groove?
5.
Approximate.
5 to 10.
5 to 6 millimeters. Okay.
From yes.
Nobody's going to catch you here.
Yes.
Retraction done.
Done.
Next.
Left
heart went.
Left went through the PFO. We'll put a
went through the PFO.
Yes.
Done. Now, how do you know this is where is the perimembranous VSD?
Yes. We put the retractor.
No. Inspection. Operation also, by the way, inspection, palpation, percussion, auscultation.
Yes.
Same order. Inspect. And you say, here is the VSD.
Behind the septal leaflet of the trachea.
How will you know it is here? Previous case was inlet VSD. This case, perimembranous VSD. Just inspection, how do you say?
Not sure.
That leaflet will be
prolapsed into the
opaque in color. Okay? And if you feel on the RA, at the AV groove is the thrill felt. Right at the base of RA appendage. Done.
Yes.
Retraction.
Retraction at the two retractors placed, one at the below the septal leaflet.
Suppose this was a small baby.
Yes.
Same question what Prasanna wants to ask, I will ask in a different manner. This is a small baby. Instead of 8 years, 8 months. What we want to say, don't use instrument, but use retracting sutures.
Yes. To the septal leaflet, the cordae, we pass a thread and just retract the leaflet.
Here, instead of retractor, we want you to say retracting sutures. So where you place them? Where is the perimembranous VSD anatomically?
Just behind the septal leaflet at the truncus aorticus. Just
Truncus aorticus.
Yeah.
First of all, it is torus aorticus.
Torus.
Torus aorticus is the atrial structure.
Just at the just at the base
Dr.
of the
Balram
septal.
has run away. Have you noticed?
At the base of the septal leaflet, below
In the anteroseptal commissure.
Yes.
Anteroseptal commissure. My four fingers are anterior and my thumb is septal. So I want to open it up like this. Keep on looking at my hand, not at my face. My face is very attractive, I know. So how do I open this angle? Septum should be pulled towards right hand, foot end,
Yes.
towards the scrub nerves. And where the ATL should be retracted to the assistant's right hand, towards the head end.
Yes.
Then you open this angle. Understood?
Yes.
So first is exposure. What questions can be asked to you on this exposure? Too many chordae crossing. What will you do? Understand?
Yes.
Or it is still not well seen.
VSD not seen.
VSD not seen still. Seen, but little bit. What will you do? Okay? We'll just avoid. Next step. What will you answer?
Assess the size of the VSD.
Large VSD.
Large VSD.
How do you assess the size of VSD on table?
With the forceps.
Achha, you pass forceps and
No.
and how much it opens? 20 degrees, 30 degrees, 40 degrees, like that. Okay, assessment is over.
VSD before surgery or
Before surgery.
does it once you opened, you are going to close the VSD, whatever is the size, no?
Yes, sir.
Chalo.
Size
Now,
for the patch.
I like students to declare a statement. And I will close this VSD with patch.
Yes.
What type of patch? Suture. What method of suturing?
Savage patch with the
I will close this VSD with a patch of
polyester savage patch.
sauvage filamentous patch.
Okay. Yes.
What
With
is so special about sauvage filamentous patch?
Use the word. Every day you are using it.
Yeah.
One answer is, if you can't give the answer, my boss uses. Is the answer. Last. But before that, yes, Siddharth. आप यूज ही नहीं करते.
The name is Savage filamentous patch.
So one side is extremely smooth, which should go on the LV side, and one side is rough, which should be on RV side.
How do you know which is smooth and rough?
Arrow.
The arrow side should face what?
Towards the RV.
Color of the arrow.
Towards the surgeon. Towards
Color
the
of
RV.
the arrow.
Blue.
Color. Okay.
Yes.
And how far away they are placed?
Sorry, sir.
How far away they are placed?
Arrows.
Arrows.
Not sure.
Where does it point? The arrow should point where when you're putting the patch?
Not sure, sir, about the point.
Arrows are placed at a distance of 1 inch. So you can cut accordingly, so you know how much you are cutting. What suture you will use?
Proline suture.
10
poly. No, 50.
50 proline.
50 proline with the
Plageted, non-plageted?
For a continuous suture, a plageted suture, sir.
Or a continuous suture ne?
Plageted. I will use 50 proline suture with the plaget with the 13 mm.
All around or only around the conduction system?
How do you use? How is it done? Describe the way you do.
All
it
around.
in our-
All around.
We take interpreted sutures all around.
All this information, can you tell me in one sentence?
Yes.
I shall close
the VSD with the Savage filamentous patch with the proline suture. 50 proline plageted proline suture around.
Needle.
13 mm, 16 mm, sir.
13 mm. What's the peculiarity of the needle which is used for VSD closure?
Half circle needle.
What is the peculiarity of half circle? Being half circle, it can include in a small space. As against that, 3/8 circle is more open, shallow.
You cannot arc it.
Retrieving the needle is a problem.
Half circle.
Very good.
Yes.
Now, standard question. Bring the screen here, please.
What are the other things that you can use to close? VSD.
Apart from we can
Apart from sauvage, filamentous, Dacron, what are the other patch materials?
PTFE patch. Can be-
PTFE patch.
Okay.
Advantage, disadvantage.
PTFE patch will have a inflammatory reaction around the
First, always talk
ATFE
good.
patch has inflammatory reaction.
Savage patch will have inflammatory
Always
reaction.
talk good first.
Yes, sir.
मौसी लड़का अच्छा है, लेकिन you know famous dialogue? Yes or no?
Yes.
So always talk good first. What is good about PTFE patch?
Porosity.
How much is the porosity? Zero.
Zero.
Number two, water non-wettable.
Non-wettable.
Bad part about PTFE? Sorry?
Endothelialization.
Endothelialization is poor.
Poor in the
Needle
PTFE.
holes,
Yes.
needle holes are large.
large.
They don't, because it is solid material.
Anything,
it is not
one of the most
fabrication.
important things practically about using it, ultimately you're going to close the VSDs, the incidence of residual VSDs has been found to be higher with a Gore-Tex patch.
Yeah.
Why? Exactly the reason you told. It doesn't cause as
cause-
much inflammation as
So
as a Dacron patch.
Hmm.
So that closes off all residual over time.
What other alternative do you have?
Manpreet, your voice is heard in that machine also. They are telling me to tell you to keep quiet. Bola usko.
Yeah. What other material
One is
are you aware of?
PTFE. Anything else? And don't forget the cost. Anything else? Can you use pericardium?
Yes or no?
yes. Yes, sir. We
Yes.
can use pericardium.
In favor against
What type of pericardium will you prefer?
Treated
So what are the
pericardium.
treatment that you do?
We treat the pericardium in the butyraldehyde solution. Butyraldehyde solution for 10 minutes.
What is used in your hospital?
Yes. 10% of the 10%.
10%.
percentage duration.
10%.
How do you keep the patch?
In your hospital, what is the
0.7%.
percentage put? How much of water is, I mean, saline is?
0.6%.
Do you use 0.6 in your hospital?
Yes, sir.
In your
How do
hospital?
you make it?
Pratik,
No, sir.
what is the percentage used in your hospital? You have all prepared the pericardium, so you should know it. It is in our hospital, we use 0.5%.
0.5.
Yeah, we
Yes.
never given them PSD closure. चलो आ जाओ. तू आ जाओ यार, तू एकदम nicely ऐसा. ये बच्चा मेरा नहीं. You know who said that? ये बच्चा मेरा नहीं.
ये बच्चा मेरा नहीं है.
विश्वामित्र.
Mike, caller mic ಕೊಟ್ಬಿಡಿ.
This I have provided you. Can we have focus? Zoom. Anyway, you can come here. You are a surgeon. Head and foot and surgeon. Surgeon. What's your name you said? Harish. Harish is a gentle giant. Okay. You are the surgeon. This is the VSD. So first you are expected to draw the surgical landmarks. You are the surgeon. This is the patient. Head end, foot end.
Surgical landmarks are generally holes.
Around the VSD.
Holes or bumps. Holes and bumps are surgical landmarks generally.
I will give you a hint. Tricuspid annulus will be another plane like this. Correct? This is intraventricular septum. All of you got oriented?
Yes.
Oriented now? Very good. This is a tricuspid annulus. Then it will be like this. Okay? Sir wants to know which part of tricuspid annulus will be that.
Surgical landmarks.
33% of chance of coming correct. Because tricuspid has got 3 leaflets. Septal leaflet, excellent. So write down over there. Now remember, who is going to see? The world is seeing. दिखता है? Very good. So any other landmark? You are on the RA side. Any other landmark on RA side?
Coronary sinus.
Coronary sinus, excellent. On RA side, huh? Tricuspid annulus. This is a standard diagram. You have to know, even if you are woken up from your sleep. This is tricuspid annulus. Okay? So coronary sinus, where it will be? Very good. Now he's almost there. See, Manpreet is very carefully, moment they come into troubleship, rings the bell. That is the coronary sinus. So moment you draw coronary sinus, what else has to be drawn along with coronary sinus? Where is the Iyer? Correct, interventricular node. So before that, what you have to draw? Tendon of Todaro, dot, 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 touching the tricuspid annulus, tangentially.
No, from the coronary
From the, how do you bring up the thing? You pull the
Coronary sinus.
It will form a ridge.
This is the IVC cannula over here. Otherwise, ऐसा हो जाएगा. This is tendon of Todaro. So where is your AV node? Apex. So if this is the apex, any other landmark from conduction system point of view on the VSD?
Till what area you have to be careful?
Sorry? Posterior inferior margin.
Up to
So
where?
where the conduction
Pratik.
system ends. Surgical landmark. Durga.
Anterior.
Durga.
Inferior margin.
What is the other landmark you to conduction system danger area? Life into the danger zone. Where is that? Mark it. Somebody.
Correct.
Mark
Now
it.
draw it. Don't get scared.
That's
Very
all you
good.
have to draw, finish.
इतना छोटा क्यों डालता है? We are big people. So from that to that will be conduction system. Draw. This is the only case where you are allowed to draw VSD as a circle. Otherwise, Dr. Seetharama Bhat will fail you. If you draw a circle first.
Happens at that
Okay?
muscle of Lancey.
This is where the trabecular part ends.
No.
Distal muscle.
What happens to conduction system at the base of the papillary muscle of Lancey?
Where does it go? How does it?
Don't keep on splitting your answer. Give a correct answer.
Is splitting.
Split that.
Split over. Split into what?
Right?
Left bundle is given by the time it reaches, and right bundle will. Okay. Any other landmark which you may see, may not see through a perimembranous VSD.
I always make it a point to show it.
Aortic root, aortic valve. So on dot, 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 dot. Correct. And go up. Shabas, go up. Excellent, excellent.
If you want to show it, what do you do?
Yes.
No. Something I always tell.
Give cardioplegia.
Give cardioplegia, you see the baby's bottom.
We used to call it Jane do. Looking at the crowd. Understood? So remember, any diagram you draw, mitral annulus, homework, morning I'm going to check, mitral annulus, aortic annulus, You draw this.
Sir, I've already given that sheet.
Already given.
Given as exercise.
So I'm reminding them. Tomorrow morning will be checked. One who has not brought it will be asked to leave. Okay? Or to give chocolate to everybody. So remember, any diagram you draw the important structures around. That itself will tell the examiner whether this candidate knows the closure. Okay? Understood?
Dr. Balram Airan is there, sir. Any comments?
Now, what about the pulmonary valve reconstruction?
We can't hear you, sir. We can't hear you. Kindly
Pulmonary
unmute
valve
yourself.
reconstruction.
Yeah, we can hear you now. Yes.
Pulmonary valve reconstruction in this patient. This patient is a case of VSD, absent pulmonary valve. So, how do we construct the pulmonary valve here? Will they know about it?
Good question.
Can you?
He has asked, in this case, it is top with absent pulmonary valve.
Yes.
What are your options for RVOT reconstruction in this patient?
Pulmonary valve reconstruction specifically, sir. Monocusp can be created with the pericardial patch, and or the RA appendage can be used to create a bicuspid valve.
RA appendage, how will you use
Commoner
it?
ones.
Conduit.
Conduit in this patient?
Sir, you're not audible.
No, I'm saying conduit in this patient? No.
Conduit, valve conduit.
No, not the valve conduit. You may have valve, but not the conduit. Hello?
Not
Can
sure.
you hear me?
Yes, sir, we can hear you.
Why conduit? Why conduit in this patient?
7-year-old.
Yes.
Sir wants to know why conduit. What is the problem of conduit at 7 years old? 7 is age.
The
in a baby?
size of the
Baby
conduit.
will outgrow.
Outgrow, yes.
So baby will require at least 2 more operations.
But otherwise also, Dr. Tendolkar, why conduit? There is no coronary
So why
anomaly
conduit?
here.
So what you can do?
Monocusp.
Monocusp, okay. You can have bicuspid. You can, if you want, you can implant the pulmonary valve and make a hood of the pericardium over that.
Yes, sir.
Why conduit? There is no coronary anomaly.
Sir, that was what he told is the first answer, sir. He said you can use right atrial appendage to make a bicuspid valve, or you can use a monocusp valve, or you can use a bicuspid valve.
But why did he said conduit?
I mean, last this one.
Third.
I think he didn't. You mentioned conduit.
No,
Yes.
sir. I was
No, I think Dr. Tendolkar mentioned conduit.
Okay, I think as far as this case presentation was there, Dr. Tendolkar passed the examination. Hello?
Okay. Okay. What are the monocusp valves that you know of? Can you tell me names?
Name of the
Monocusp valve, what are the types?
Yes.
Names you can give, or if you want, if you can't name, please describe.
Pericardial patch, which is used.
Generally, you don't use a pericardial patch because the pericardium tends to stick and remains open. You usually use either PTFE or any other homograft. You can use the body, I mean that this one of the homograft, you can use one of the leaflets as your patch, but generally pericardium is not used. Okay, so PTFE.
PTF.
Have you heard of Nunn valve? Graham Nunn.
No.
Yes or no?
Yes.
Anybody in the audience? Graham Nunn valve? NU-double-N. No.
None have heard.
Okay, none have heard. None technique. Homework? because it's going to take a little time to explain. Homework, let us have a discussion tomorrow if you require. Second type of valve is SUNG, S-U-N-G.
Yes.
Both these two are modifications. The third variety is where you augment the existing leaflet. These are the three types of monocusp valve that you can use. You can also use if you are using autologous pericardium, then you can do Ozaki type of reconstruction for the pulmonary annulus. These are valve reconstructive procedures in RV outflow tract obstruction.
Okay, sir.
Just one question can I ask, please?
Yes.
In the echo report, they said PDA absent. What if PDA was present?
Will it be ever present? Never.
Can you appreciate that answer question? The PDA was absent, but suppose they written PDA present.
No, sir, it cannot.
Compatible with life or not compatible?
Not compatible because there will be constant flow through the PDA. With PDA. Yes, sir. Thank you, sir. Thank you, sir.
Hello.
I request Dr. Balram Iyer, sir, to tell us regarding the candidates' performance and to give them points to improve.
Well, I think the performance of the candidates, I'll say that it should not be judged because they did not have enough time to speak. And out of the two boys, the fellow with the blue shirt, what is his name? He did better than the other person. But both of them were not up to the mark. They got to read the subject. They should know how to present the cases. And they should know what they have to speak. Because if you speak something wrong, that will lead to further questions in that direction only. So be precise in your answers. Go and read. All right?
Thank you, sir. Thank you.
Thank you, sir.
Yes, sir.
Dr. Brijesh, can you give
do
your
you have
comments?
any comments for our candidates?
Yeah, Brijesh, please talk. No.
Yeah. So basically, I would add that in the exam, one of the important point, as Prasanna sir has told previously, is that contradictory findings shouldn't come. For example, if you look in, you were telling this, your diagnosis primarily has a VST-PS, but there were contradictory points which you were pointing out. One, that the patient had a pansystolic murmur, which was suggestive of a restrictive VST. But on the X-ray, you were saying that the patient had cardiomegaly. So these, if there are contradictory findings, then you should definitely look at answers for that. The final diagnosis is a tetralogy with absent pulmonary valve. So if you now from the echo report, when you look backwards, you will understand that certain points you might have missed it. The pansystolic murmur, you have probably looked at the pulmonary regurgitation, which produces a systolic and a diastolic murmur, which may radiate down, which you have attributed to the VST and has as such caused that mistake. Second, when you look in, if you have picked up that if there was a diastolic murmur, then the X-ray would corroborate you with the cardiomegaly. And then the only thing which will come for the diagnosis is whether it's a absent pulmonary valve tetralogy or a VST with aortic regurgitation, which you might have easily picked up by identifying where the regurgitation murmur, whether it's in the pulmonary area or in the aortic area. The ECG would again give you a diagnosis. ECG showed right axis deviation with early transition, which is indicative of a tetralogy. So the aortic regurgitation goes out and tetralogy with absent pulmonary valve would be diagnosed. So tetralogy with absent pulmonary valve, you can diagnose this clinically with the findings ECG and echo before ECG and X-ray before you reach the echo. So it is clear you might have missed certain points. if you have diagnosed VST PS and then you are presented with ECG X-ray, then you will not be able to stand there. So as Prasanna sir said, you should go till the final end, and retrospectively you should look at the findings before presenting to the examiner. You should be able to defend each point with your finding. If there is contradictory finding, you should be prepared to go back to your diagnosis and come up with a differential diagnosis.
Thank you, sir.
Yes, sir.
We have a small change in the program. We are unable to contact Dr. Ali Zamir Khan. So I request Dr. S.V. Sri Krishna, consultant surgeon at Narayana Mazumdar Shaw Medical Center, Bommasandra, to guide us through how to present a thoracic case.
X-ray I'm going to show. I'm not going to give a talk on X-ray because it is after lunch. And with hypothermia and hyperglycemia and blood flow directed towards cilia and superior pituitary, carotid signals are 0. So I have got on CD X-ray, diagnosis written below the X-ray. But the whole idea is to describe and tell why is this diagnosis.
Another thing is,
now I'm going to start serially at randomly, sorry, not serially randomly. So those who have not spoken since morning will be picked up.
and another thing that I just want
I hope everybody will be there after lunch. Don't go anywhere.
echo everything
to the student.
And you have to build a comprehensive case and management. So you mentioned if the X-ray, ECG, echo don't correlate, also you have to be able to tell why.
Let us give Sri Krishna a chance.
Okay, this is a makeshift presentation since Zamir is not available. Many of you are adept at presenting a cardiac patient or a cardiac case, and very few of you are actually exposed to presenting a thoracic case. So how do we go about it? Basically, the system is just the same. You have the history, physical examination, and you have to come to some sort of a differential diagnosis, preferably, and then with the investigations, nose down to a particular diagnosis and then plan your treatment. So this is how it should be done. So usually the specific respiratory symptoms are breathlessness, wheeze, cough, sputum or hemoptysis, chest pain, fever with rigors and night sweats, weight loss, and sleepiness. So just like the normal course of presentation, you have the initial presenting symptoms, then you have past medical history pertaining to the respiratory diseases and other illness. In respiratory disease, remember that these are chronic illnesses and many of them would have gone through many places. So please always look for older reports and older images. And then you will know the progress of the disease, how it has come up to the present day, to the present when they have presented to you. And then you can make up your diagnosis. So then, of course, the standard drug allergy and history and the social family history, occupational history is important in a thoracic patient because they are prone for, many of the occupations are prone for respiratory illnesses. So you must, and smoking history is equally important. Then, of course, there are many places, many conditions where systemic diseases are also associated with chest conditions. So you have to have these things in your history. So let's go on to basically what they are. Breathlessness, you have to talk about the onset. It could be an instantaneous breathlessness, which could be seen in pneumothorax, pulmonary embolism, acute allergy, acute LVF, inhaled foreign body, and things like that. It could be over hours. So asthma, acute pulmonary edema, or an acute infection. Or it could be insidious in onset over a period of time. And these could be effusions, interstitial disease, tumors, anemia, neuromuscular disorders, and also you can grade this breathlessness according to, just as you have the NYHA class in the cardiac system, you have what is called an MMRC grading. And it is very similar to the NYHA class. And you have grade 0, where there is no only on strenuous exercise. The grade 1 is shortness of breath when hurrying on a level walking or slightly uphill. Grade 2 is slower than the level walking. Grade 3 is they have to stop every 100 meters or so, and grade 4 is that they are not able to carry on with their regular work. This is available in all textbooks and literature, so you don't have to bother. Next comes the wheeze. The wheeze is a symptom where you have airway obstruction, which causes increased difficulty in breathing and associated with a noisy breathing. So the age of onset, usually wheezes are present in the younger age group or in allergic phenomenon. If you are talking about asthma, it is usually seen in a younger age group. But if you see wheeze suddenly occurring in an elderly person, somebody who after 50, that means this is a new onset wheeze. That means there is some sort of a bronchial obstruction which is causing the wheeze. So that itself gives you a clue whether this is a congenital or like asthma or COPD, or it is an acquired disease. Especially when they are related to posture, it could be because of tumors. Then you have cough, similar. You have to know about the duration, whether they are dry and productive, whether there is postural variation. If you have postural variation of the cough, it is generally seen in cases of bronchiectasis or lung abscesses. And there's one specific variety of bronchiectasis in tuberculosis. It usually affects the upper lobe, and that is called bronchiectasis sicca. There you don't get much of sputum or sputum production. So because it is draining into the main bronchi and they are expectorated out, usually bronchiectasis in the upper lobes are dry, usually dry. Then they, as usual, they could be associated with fever, chest pain, or hemoptysis, and then you have the aggravating and relieving factors. So some of the common causes of chronic cough is suggested by the history and examination. Asthma cough variant affects children and some adults, often present at night, associated with wheeze or atopy. Chronic obstructive disease is usually common in smokers, and they usually have, along with them, intermittent sputum. Persisting airway reactivity following bronchitis, and as I told you earlier, bronchiectasis and lung abscesses give rise to profuse sputum production. And persistent cough can also occur in lung cancer. This is another very common things that we see in our situation, because a patient has cough for about a week. He goes to a doctor, he gets a course of antibiotics, the cough doesn't subside. And then he goes to another person and gets another course of antibiotic. And after 2-3 of these episodes, then somebody suspects him to have TB and they put him on anti-tubercular treatment empirically. And then subsequently, when there is no improvement after 3-4 months, they come to then they start getting investigated. Somebody does an X-ray or somebody does a CT scan, and lo and behold, they are discovered to have a mass lesion. This is the natural history that happens, and that is why we see these patients much later. Then the other common causes of cough could be esophageal reflux, drug effects, interstitial diseases, and this idiopathic cough as well. Sputum production, we have already said that. In this, you have to see whether the color is clear, mucoid, or it is purulent, or it is affected with, the greenish sputum is usually seen in Pseudomonas infections, and rusty brown color is usually seen in pneumococcal pneumonia. Consistency is again important, and the volume of the sputum. This is another very common history that you get. Hemoptysis, again, the quantity, quality, whether it is frank blood or whether it is streaky hemoptysis or it is pink and frothy. And the duration and frequency differentiate from epistaxis, oropharyngeal bleed, and hematemesis. Why I'm going through all these symptoms? These are the symptoms that a patient comes to you, and you have to analyze, looking at each and every symptom, and then sort of combine all of them, and then sort of come to a differential diagnosis. This could be the possible reason. A patient who comes to hemoptysis, generally, streaky hemoptysis is usually a cancerous lesion, whereas a massive hemoptysis could be due to a tuberculous bronchiectasis or an aspergilloma in the lesion. So that itself gives you a clue what is going on with these patients. So massive hemoptysis is considered, there are different definitions. Each textbook gives you a lot of definitions. Ultimately, it is what you have to follow in your own practice. Maximum hemoptysis is something which is considered as 600 ml more than 24 hours. More importantly, it is the quantitative and the qualitative aspect of hemoptysis, which is important. And even 100 ml of sudden hemoptysis can cause hypoxia, flooding of the lungs, and can be life-threatening. So these definitions may not be as important as what you see in front on your patient in front of you. Massive hemoptysis involves disruption of the bronchial or pulmonary circulation pathologically exposed to a high pressure of bronchial circulation. And bronchial artery tree becomes hyperplastic and tortuous and increase in capillaries due to adhesions. So sudden cough and sudden this thing can give rise to a massive bleed. These are the various causes of hemoptysis that you can see. The commonest would, in our situation, would be pulmonary TB, bronchiectasis, and CA lung. Benign tumors can also be possible. AV malformations and fungal infections are more important. And of course, aortic aneurysms and pulmonary artery aneurysms can also give rise to considerable hemoptysis. In TB, what happens? This may be asked to you in the exam, because what is the mechanism of hemoptysis in tuberculosis? Because that is the commonest case that you will get in your exam. Erosion from a healed calcific node, acute ulceration of a bronchial mucosa, or destroyed architecture of lung as in bronchiectasis. These are the common causes of hemoptysis in tuberculosis. We have talked about this already. And chest pain could be either cardiac cause or a non-cardiac cause. So, and in the non-cardiac cause, you have to rule out a respiratory effect, respiratory causes of chest pain. And these could be because of malignant pleural disease, pulmonary edema, and then pneumonia with a pleural infection, pneumothorax, connective tissue disorders, and rare causes could be because of pulmonary artery hypertension, severe distension of the pulmonary artery, central pulmonary artery, asbestos-related pleural plaques, and then iatrogenic causes of chest pain. Cyanosis and clubbing, again, there's a differential diagnosis, whether they are respiratory causes or cardiac causes. In respiratory causes, the common are chronic obstructive pulmonary disease, collapse and fibrosis of the lung. Pulmonary AV fistulas are commonly give rise to cyanosis, clubbing. And high altitude. You see this more common in patients who are general population who are in high altitude. Of course, you know the cardiac causes. We have discussed this already. Cyanotic congenital heart diseases and the Eisenmenger syndromes and CCL. These are other non-specific symptoms that you come across: fever, rigors, night sweats, weight loss, and smoking history is important. So once you've got this, you have a general idea whether this is an infective congenital pathology or an infective pathology, or is it a tumor? And if it is a tumor, whether it is a benign or a malignant tumor. This is all that you have to see. Of course, don't forget trauma. Trauma can cause a lot of problem within the chest. So inspection, look for asymmetry, quietly observe the time and respiratory rate, whether the patient is in respiratory distress. Examine the hands for finger clubbing, check the pulse, examine the JVP, general physical examination as you all are used to. Locate the apex. Apex beat will tell you whether there is any mediastinal shift, whether there is a collapse of the lung causing the apex to be shifted towards the lesion, or if there is a effusion, the apex beat may be pushed away from the lesion. Check for asymmetry and look for vocal frematous and areas. Percussion is generally, it is quite important in a chest condition, unlike the cardiac patients. Cardiac, you are only trying to confirm whether there is cardiomegaly, and there are other ways to do that. But in chest X-ray, dullness is important, or hyperresonance is important. If there is hyperresonance, you could be having a pneumothorax. If you have dullness can cause because of a consolidation. It could be fluid, or it could be a mass lesion. In consolidation, if you have, it is just a woody dullness. It's described as woody dullness. And if you have fluid, could be effusion, could be empyema, could be hemothorax, then it is classically described as stony dullness. Okay. And then there are other features on examination which will tell you whether it is consolidation, whether it's fluid, or whether it is a mass lesion, depending on your auscultatory finding. When you take for auscultation in a consolidation, you will always find bronchial breathing. In a fluid, whether it is empyema, hemothorax, or just an effusion, you will have absent breath sounds. And again, even in a mass lesion, you will have absent breath sounds. Okay. So the tracheobronchial tree classically divides into 23 times. So from the trachea to the alveoli. So as the air goes through these different divisions, the intensity of the sound goes down. That is why when you hear in the periphery, you will hear vesicular breath sounds, whereas when you auscultate in the central airways, you will find bronchial breath sounds. So you must know how to differentiate bronchial breath sounds from vesicular breath sounds. Bronchial breath sounds are classically described as to and fro sounds with a gap in between. The expiration and the inspiration are generally of the same duration, whereas vesicular breath sounds could be the inspiration is twice the amount of expiration, but because the intensity of the sound goes away as it goes further out into the periphery. So differentiation and bronchial breath sounds are classically seen in a case with consolidation. So you have a lesion, you have a patient who has got dullness in a particular area, and you hear bronchial breath sounds on that area, then be sure that it is a consolidated lung. That means the consolidation is that the bronchi are patent, allowing air to go in and out, and the parenchyma is filled with fluid. So it is transmitted to the chest wall. So that is why you get bronchial breathing. Then you have wheeze. Wheeze is a musical whistling sound, and crackles. Crackles are classically seen in bronchiectasis, or where there is fluid within the alveoli accompanying deep breathing, and they are thought to represent a sudden opening of the small airways, but sometimes may indicate secretions in the airways and underlying fibrosis. And then you have what is called as a pleural rub, and it's a rasping, grating sound, which is usually seen in the early stages of pneumonia. And with each breath, there's a scraping sound that you can see. And you can also find this in early pericarditis as well, what is called the pericardial rub. So this inflammatory roughness of the surface of the either the pleura or the pericardium gives you this grating sound. So then you have this stridor. Stridor is a sudden obstruction of the airway, especially in the central airways, because there is a noisy breathing produced by obstruction of airway from the central airway, that is the trachea and the main bronchi. This could there are subtle ways of differentiating whether it is an intrathoracic mass or an extrathoracic obstruction, which may not be that indicative, because you are always going to do a X-ray, CT scan, and then see where the obstruction is. So as I told you, main thing that you people will be getting is, as Hiremath in the morning said, that you could get an empyema. So you must see whether this chest lesion has got fluid, or it has got a consolidation, or it's got a mass lesion. If it is fluid, well, then you have to know whether it is just an effusion, or there is empyema, or there is hemothorax or chylothorax. How do you do that? That you have to do what is called the aspiration, this cytology. And you all know, I hope you know, the Leitz criteria. You have to differentiate between a transudate and an exudate. And a transudate will be usually because of just fluid, and classically seen in the three failures: heart failure, liver failure, and kidney failure. These are transudate. If there is some amount of infection, it becomes an empyema. And empyema, you have to know the three grades. You have the exudative grade, the fibrinopurulent grade, and then the organizing grade. So in an examination, you might get an empyema. They will ask you what is the stage of the disease. So if it's fibrinopurulent, you can just ask for treat it with an ICD. If it is fibrinopurulent, you can do it with VATS. Nowadays we do VATS drainage and then put proper ICDs and drain it. If it is organizing phase, where there is crowding of ribs, there is pleural thickening, and there is loss of volume of the chest cavity, then you may have to resort to an open thoracotomy and decorticate. Then, of course, you have the mass lesion. As I told you earlier, it could be a benign or a malignant. A benign lesion is usually having a smooth margin on the X-ray, and the surrounding lungs are usually normal with a thin walled cavity. Whereas in a malignant lesion, it is thick-walled, it has got a varying consistency. Sometimes you can even have calcification and these problems. So you have to differentiate these things. And of course, the other things that you might get in your exam is a mediastinal tumor. You have to know where the mediastinal tumor is, whether it's in the anterior mediastinum, middle mediastinum, and the posterior. Classically, there are 4 T's for the anterior mediastinum. It is the tumor, thymus, thyroid, and then a teratoma, or a terrible lymph node, or a tuberculous lymph node. These are the 4 T's. And in the middle mediastinum, you have the A's, the aneurysms, either the aortic or the pulmonary aneurysms, or you can have an adenoma again, and you have aneurysmal, abnormal cysts. And in the posterior mediastinum, you usually will get across to see neurogenic tumors, again lymph nodes, and again some amount of esophageal diseases or teratomas and things like that. So these are the things. So this is all that you'll probably get in your exam. You just have to keep a watch on what you're saying. Again, please don't ever go with a prefixed idea, even as we have seen this in the morning. If you are even told the diagnosis, please don't go on the prefixed idea. You have to have a differential diagnosis. You have to discuss the case and then come to a diagnosis and then ask for relevant investigations and then take 2 minutes, 3 minutes before you go to the exam, before you tell the examiner what you're going to do. Read what you have done, what you have written, think about it, and then come to a differential diagnosis always, and then discuss. You may be wrong, it doesn't matter. As long as you can defend yourself, as long as you can justify what you're saying, then the examiner has no business to fail you. All right? So this is how a simple and thoracic case, you don't have to be very worried about it because you have not seen it very often. But it's much easier to go through in the same systematic way. Okay? Any questions? Yes, sir.
Just like cardiac correlation, they should also know from lung. Just like cardiac correlation between heart sound and hemodynamics, clinical finding and a lung pathology, you should be able to correlate. Decreased heart sounds means what? Bronchial breathing means what? Tracheal shift means what? So that is, and then create a composite picture. So exactly what we have been doing in cardiac, same thing holds in lung. That you are finding, you should able to tell what does it mean pathologically. That is very, very important. That is where the students normally fail to correlate.
Very right, sir. As I told you, you have dullness on percussion. You have to differentiate between pneumonia. You have to differentiate between fluid, and you have to differentiate between a mass lesion. You have a hyperresonant area. You have to differentiate between pneumothorax or an emphysema or a giant bulla. This is all that is there. Right, sir?
Another thing is always the back. People don't examine the back. Very, very posterior.
Yeah. Yeah, that you have to have an overall this thing. That true. Well, we can't teach the entire thing right from MBBS days and things like that. But anyway, you are all appearing for the last exam in medical profession. So you should be talking like a consultant and not as a second MBBS student. All right. So as we discussed in the morning, we said you have to present a case just as the patient has told you or patient's relative has told you. But you have some amount of knowledge. What you have to do, you have to edit what you're going to say. And sometimes you may have to have omission or sometimes you have to have commission. So it's basically common sense. This is like a court of law wherein you are the lawyer and you have to convince your examiner what you are saying is correct and what you're going to do. Right? Thank you.
Thank you, sir.
Extremely good. You are convinced the examiner that you are capable of handling the patient.
Thank you, sir. Let us now break for lunch. We will resume at 2 o'clock. 2:10.
Our creator.
Lunch is arranged at the 4th floor of the building.